Hi, I'm Veena Mahajan. I'm a vitreoretinal surgeon here at Stanford University, and I've been having fun hanging out with Prithvi for the last several years. I'm going to talk about proteomics of the tumor meso environment. I'm going to try to introduce a new term. This is mostly work done by Julian Wolfe and Soo-Hyun Lee. There's no specific conflicts for this talk. We've been talking for a few years now about aqueous humor liquid biopsy and what we can learn about uveal melanoma, and specifically comparing it to the sort of gold standard direct tumor biopsies. And in the last couple of years, we've talked about how we can grab a little bit of fluid and measure a lot of proteins. This could potentially help reclassify tumors, tell us about metastases, indeterminate lesions, and potentially identify drug pathways. I'm going to talk a little bit about an update from a method that we published on. We call it TEMPO. And in this instance, what we do is we get about 50 microliters of aqueous humor. We use a proteomic platform where just in those few drops, we can measure close to 6,000 different proteins. And then using a single-cell sequencing atlas that tells us all the genes and which cells they come from, we can match them to all these proteins to different cells. And in this cover image, basically, if we find a red protein, we can match it to the red cell. If we find a blue protein, we can match it to the blue cell. And the cool thing is these single-cell sequencing atlases, they all came from human path tissue from when the patient was dead. But we're collecting these liquid biopsies from patients that are living and capturing a lot of molecular information about what's happening in the eye. We've done this for diabetes and uveitis, but really a strong interest in tackling uveal melanoma. And so today I'm going to talk about, well, here, this is a figure that I think we showed last year. So if we capture aqueous fluid, what was remarkable is that we can measure 160 proteins that can only come from a uveal melanoma tumor cell. We can also identify 38 proteins that only come from tumor macrophages and 40 that come from T cells. So this is much bigger than any kind of immunohistochemistry study that you could do in the path lab. And again, it's from a living patient. And we're now at the point with the data that we've reviewed from all sorts of different eyes, is if you sent us fluid and you never told us anything about the patient, we would know that we're looking at a uveal melanoma patient. So this is TEMPO 2.0. This is what I'm going to describe in a few minutes today. And so a lot of times people want to know, inside the tissue, inside the body, how are cells actually communicating with each other? And what we're showing in the first panel there is you have these cells. One cell is secreting a ligand. The other cell has a receptor. And we now have these single-cell atlases of gene expression showing maps of how cells could potentially be talking to each other. Based on several of the single-cell sequencing publications for uveal melanoma, we can actually look at these cells now and see which of these cells are making a ligand, potentially, that another cell inside the tumor would have the receptor for. Now, again, these are on path tissues, and these are predictions because this is looking at RNA. The presence of an RNA doesn't tell you if they're actually making the protein. But now what we did is we collect aqueous humor liquid biopsies where we can actually measure the proteins. So we can actually look into human eyes, patients that are living, and see if these cells are talking to each other. And I'll give you one example of that result. So this is looking inside the tumor microenvironment and asking, do the patients, are they actually have immune checkpoints that are actively taking place in that patient's? And so I'm not going to be able to point, but just if you look at the Nectin-1 CD96, you see these red dots go across, and then the red dots disappear. We had a previous classification that we talked about where we classify the tumors. These are roughly small, medium, large, roughly. But you can see that there's one immune checkpoint that are in this, what we call our PEP1, PEP2, or these small, medium tumors that's absent from the large tumors. where instead, in the larger tumor, those big blue dots in 2 rows, you see immune checkpoint signaling between Nectin-2 and 2 potential receptors. What this means is that we could take a liquid biopsy of a uveal melanoma patient. We can actually see the immune checkpoint ligands that are communicating within the tumor microenvironment. And if you had this knowledge, you would be able to select and enroll and stratify your patient for the right immune checkpoint inhibitor. We've done all sorts of other kind of signaling between cells in that tumor microenvironment. I don't have time to go into that. Now, in our original study, we also used a single-cell sequencing atlas of the entire eye, cornea, ciliary body, everything. This is in the tumor microenvironment. We're just looking at the single-cell atlas of the tumor. When we included that large atlas that would include tumor and whole eye, we saw something really unexpected. That was that tumor cells are actually sending ligands out to normal cells in the eye, and normal cells are actually sending ligands to receptors within the tumor. And so these sort of pretty diagrams here in the far left panel A, the tumor, which is red, these little red lines that are going out to all these different cells are ligands for which the other normal cells in the eye have receptors. And the gray lines are ligands that, for example, glial cells, rods, ganglion cells are making ligands where the tumor cell actually expresses the receptor. And we did this for both the tumor T cell and tumor macrophages. And you can see in the tumor macrophages, it's sending out a lot of these lines are a little thicker or fatter. So there's a lot of proteins that it's sending out that normal cells around the eye respond to. And then the normal cells around the eye are actually sending ligands where that tumor macrophage actually has receptors. So here it is in cartoon form, where it really appears that the tumor, the uveal melanoma, is actually talking to different cells throughout the eye. This is a different way of displaying it, but I'll just point to the graph with the big yellow dot there is. It appears that the tumor T cell and then normal fibroblasts throughout the eye are sending out ligands to the tumor that would drive epithelial to mesenchyme transition. So I think this is really a new idea because we're always focused on the tumor itself. When we look at histopathology, we're looking at a slide of just the tumor, but there's a lot of crosstalk actually taking place in our patients, which changes how we would think about potentially different kinds of therapeutics and really the mechanisms of the cancer. So we introduced, when we were looking at this data, a lot of work obviously done on the tumor microenvironment, a lot of understanding of the tumor macroenvironment, where the tumor is influencing things far outside the body. Here, since we're mostly ophthalmologists, we're sampling right inside the eye. So these are little fluid pockets that are not inside the tumor but adjacent to it. And so we looked up on Google, hey, what's in between macro and micro? And that's the middle is the mesoenvironment. And this kind of environment of fluid exists for a variety of other cancers. In lung cancer, with a fluid pocket that's necessarily outside of the tumor, but close to that cancer, but not somewhere far away at a distant metastatic site through lymph and through blood. So I think this is, with the eye itself, we have this, almost enclosed small area that gives us insight into this for our patients. But I think it's something that we're going to find that's broadly applicable across different kinds of cancer. We observed this, and then this is a sort of a complicated image of where we go to validate it. One of the things that we did, which was pretty cool, is we actually took vitreous biopsies, and with a buddy at the University of Calgary, Tony Dufour, we actually did phosphoproteomics. And so if you're studying cell signaling, it's nice to find the ligand, it's nice to find the receptor, but you really want to find, did something happen inside that cell? Was there a signal inside that cell? And from the vitreous, we were able to collect proteins that only come from inside the cell and actually see that they're phosphorylated, evidence of a signaling event. One of the molecules that's floated around in uveal melanoma is KLF4. It's a transcription factor, well known in a variety of other cancers, but we can actually see phosphorylation of KLF4 in individual patients. And what this zigzag line here is, we're actually following specific ligand proteins that came from normal fibroblasts or normal ciliary body cells. They activate receptors that are on uveal melanoma cells, and then we actually pick up phosphosignals inside those cells. And this, I think, is probably one of the first phosphosignaling done inside a human, especially for cancer. And then on the far right, we have some Western blots, but what we did is a co-culture where we actually got primary human fibroblasts, primary human ciliary body cells. We co-cultured them in that little dish where they're separated to actually see, are they sending out those signals to a layer of uveal melanoma cells. And we can pick up phosphorylation events, and we can pick up those epithelial to mesenchyme transition events that we were surmising. So this is a validation of what we were seeing in our humans. I think it brings up the intriguing idea that if we want to treat a cancer, we always want to target that cancer cell for sure, but are there normal cells near that cancer cell that we could target that would also enhance control of that cancer? Because there is that kind of crosstalk. So this Tempo 2.0, we can actually see tumor microenvironment signaling in individual patients with uveal melanoma. There's this new concept that we're trying to introduce of a mesoenvironment, nearby normal cells that are communicating. And this may lead to better ways to stratify patients and really think about precision oncology in uveal melanoma. And then thanks to all the people. Thank you. I'd like to introduce my buddy, Jesse.
Thank you. We all know each other. All right, you guys. So I'm actually presenting for Dr. Leah Xu, who's not able to be here today. And most of this work is unpublished and in process. So if you take any pictures, please don't share them. We're going to talk about aqueous humor proteomics as a companion diagnostic for melanoma. This is my research funding. All right, so we know this, that even with therapy, nearly 50% of melanoma patients will develop fatal metastatic disease, and that while conservative treatment is very successful in melanoma, we're very good at that, I think there are still two issues that we as ocular oncologists have on our shoulders. One is what to do with small lesions. What are they? When do you treat them? How do you treat them? And Mets. And many, I think, take a watch and wait approach to small, what I'm going to call right now, indeterminate melanocytic lesions. And I think the diagnosis of these small lesions is subjective. I know, for example, I have a patient that I think probably has a small melanoma and has seen multiple different ocular oncologists. And like amazingly, you think that's a yes/no answer, yet like every ocular oncologist gave him a somewhat different answer. Some of you guys are in the room. And so we don't actually really know what this patient has. And of course, it's a 1 millimeter lesion with orange pigment and subretinal fluid right adjacent his fovea, right? So, but it's growing very slowly. And he's young, and he has a lot of orange pigment and a lot of subretinal fluid, right? So, and it's harder to biopsy these lesions because they're often in really tough areas. So, is there an issue to watch and wait on these? If you say every lesion that's 1 millimeter, we're just going to watch and wait. Well, some of those lesions grow, right? So at some point you can watch them, but when do you stop waiting? And there has been new and evolving discussions about deferring treatment for small melanomas and increasing the risk of metastatic disease. Dr. Scott and I will be discussing this for the AAO actually in a couple of weeks. And this is from our colleague, Dr. D'Amato, and he wrote in this paper that deferring treatment of choroidal melanomas until documentation of growth may delay vision loss by months or years, but is associated with a minimal increase in metastatic mortality. And so here's an example from my clinic. So this is a patient who had a 9 by 2.3 millimeter lesion, but no significant orange pigment and no subretinal fluid. This had been watched for some period of time, and the decision was to continue to watch and wait. This patient then went to another state and was seen about 16 months later. So that's not a humongous amount of time, right? That's maybe 2 or 3 times the amount that we'd want for him. But at that point, 16 months later, it was 12.31 by 5.63. So clearly this lesion had transformed. And so is there a way in which we can identify these patients earlier? That's sort of the question that I think many of us struggle with. And so we have identified that we know that you can biopsy these tumors and identify many markers, but that cannot always be done in small tumors, and it's very hard to repeat them. So can you use the aqueous? So Dr. Martine Jaeger's lab actually was the first, to my knowledge, to publish on aqueous humor for uveal melanoma, and she actually did this from a retrospective data set looking at cytokines. And then we published looking at the potential for looking at DNA in uveal melanoma. DNA in melanoma is not quite as much of a slam dunk as it is for retinoblastoma, so we then went on to look at proteins, and as you heard from Vinu, proteins are really exciting in melanoma. So first we looked at prognostic utility, identifying these patients before they get there, right? And we did O-link analysis, which looks at about 1,500 proteins from a very small amount, about 20 microliters of aqueous humor. And in our initial subset, we had 20 patients. There were some differences in AJCC tumor criteria by GEP status, although as Prithvi pointed out earlier, you would expect that. And you could see here, based on PCA analysis of the proteins in the aqueous humor, there tended to be these 2 clusters between GEP1 and GEP2 patients. Again, these are patients who had biopsy-confirmed GEP1 or GEP2. I guess you can say that doesn't mean they have biopsy-confirmed melanoma. That was a clinical diagnosis that I made. And you can also see that there were 3 patients that I did not biopsy in my hand, so we, do not know the GEP classes, and they clustered with group 1. And so we found in this initial study that there were 45 differentially expressed proteins between the GEP1 and the GEP2 groups. And you can see some overlap here from some of the tempo that Vinu just discussed. And there was a fair amount also of inflammatory genes or inflammatory downstream protein targets like the TNF family, as you can see here. And we also found that these proteins were involved in metastasis-associated pathways, which makes sense, right, if they are correlating with GEP2 patients. So okay, you've got some evidence for prognosis, fine, but that doesn't really help us with diagnosis. So is there anything we can do for diagnosis? When you see a patient like this, and you're not sure if this is a nevus or a melanoma, I don't know how many people would have treated this as a melanoma at this stage before you saw what happened to it. Is there anything that we can do? And so, again, we've got some new and exciting work out of Stanford that was already shared with you guys today. So we first looked at uveal melanoma versus glaucoma, really with like a pretty broad question, like in a glaucoma patient who presumably does not have cancer in their eye, right? And in a melanoma patient, is there a difference in the proteins? And we found that yes, with the upgraded O-link panel, which looks at about 3,000 proteins, we did find that there was a differential expression of these proteins, and that you could delineate between control and uveal melanoma samples. Not perfectly, right? You see that there's a ratio here of glaucoma to melanoma. And there's a decent area under the curve here, 83, for diagnosing melanoma based on the protein expression in the aqueous. Does that make sense? Like, is this sample glaucoma or is it melanoma? Okay, great. And it also differentiated between large and small lesions, which may go back to prognosis. So then, and this is unpublished data, so then we went back and now instead of 20, we had 47 samples to look at. And we wanted to say, okay, we had our 2022 cohort where we found there was a difference, and now we have a new group, 2023. Can we replicate that difference? Can we replicate that protein signature? And so what we found again is that both cohorts do tend to have this differential expression of proteins with up and down regulated proteins, and they tend by unsupervised clustering to go into these nice two groups. What was interesting though is that the proteins that we found were not exactly the same. And, I don't know if you guys can weigh in on this. This wasn't, we have to share data that's not perfect either. This wasn't the perfect data that I was expecting. There were 15 proteins that overlapped. So maybe this is due a little bit to sample heterogeneity. As you can see here in our cohorts, there was a little bit of a difference between GEP1 and GEP2, PRAME status, and ciliary body involvement. And so what we found is we looked at those 15 overlapping DEPs, saying that these are in our two cohorts, and by PCA weighting, we said which of these contribute most to differentiating between class 1 and 2. And the 7 proteins on the top were the 7 most differentially expressed proteins. Now you'll see here, we put lag in here for UV-NU. Lag in the Stanford group's really beautiful data has been one of the more significant. We didn't see that in our data. I don't know why. And so again, you can see here that there's good sensitivity and reasonable specificity using this 7 protein training set to get even more patients appropriately diagnosed with that area under the curve. And then I asked our team, okay, so if the whole idea here is for small tumors that maybe we can't biopsy, can you go back to the unknown patients? And so in our unknown patients, these were the positives and the negatives. Positives mean correlating with group 2. This is maybe a little bit higher than we would have expected if we think 30-70, 1 and 2, but definitely more group 1 than group 2 in these small lesions. So a lot of work needs to be done here. I missed some of the early AI stuff, but I think let's put AI and aqueous together, right? And have some really informational clinical imaging and molecular data sets and get some of this stuff put together for these small tumors. I don't know if this 7 protein panel is going to be it, if there's going to be others, if it's going to be tempo, but I can tell you that we're gaining a lot of information that may help us also for uveal melanoma. Thanks so much.
Excellent job.
Thank you.
All right, so I will talk about the living library for uveal melanoma. Again, same disclosures as before. I might still be too short for this. Let's see. And this was funded by both NIH and Mayo Clinic internal funding. Again, I'm not going to belabor the points about uveal melanoma. We know this is a bad disease, and we know we don't have good therapies once patients get metastasis. So we really need collaborative translational research in this arena. Unfortunately, most uveal melanoma work has been done in the lab on a limited number of commercially available cell lines, and many of those cell lines were derived from tumors that were atypical. And over time, those cell lines now deviate in chromosome status and even melanocyte markers from the primary tumors from which they were derived. And some of these cell lines that we still get coming through IOVS to try to claim to be uveal melanoma papers were actually cutaneous-derived lines. So we need better models, and this has been my labor of love over now the past 5 years to develop and characterize more representative models of uveal melanoma so that we can better understand this disease and hopefully have more translation of treatments that we develop in the lab. So the first question we asked was, can we use primary uveal melanoma tissue to establish patient-derived organoids? This was easily accessible to me, but patient-derived organoids were a new concept that I learned from my medical oncology colleagues. These were 3D tumor models that we can generate directly from tumor harvested from our patients. And these really bridge an important gap between 2D culture and animal models in that they much more closely resemble in vivo pathobiology of disease, but compared to animals, they're more high throughput and these are more affordable. Some of my colleagues in other diseases like GI tumors have shown that PDOs have really good correlation to patient clinical response, so we're hoping the same is going to be true for uveal melanoma. So since 2019, through the prospective ocular tumor study, I've been collecting primary tumor samples. We'll talk about the expansion to metastasis in a little bit, but we isolate these using a human tumor isolation kit with a gentle max dissociation protocol. We use Cultrex, which is basically a similar Matrigel-like substance that was still available in the pandemic, which is unfortunately right after I just started my practice. We use a supplemented RPMI media, and we have a good workflow where we biobank these, we analyze them to confirm with immunohistochemistry and immunofluorescence that they are melanocytic cells, when we do genetic analysis, and we can do drug studies. So at the time of this presentation, we successfully established patient-derived organoids in 40 of 44 attempted primary uveal melanoma cases. As with the disease, these were predominantly white, similar men and women. We had a wide age range of patients, a wide pathology range. We've covered all of our classes of gene expression profiling, PRAME positive, PRAME negative, and BAP1 retained and BAP1 loss. So you can see here, the orange ones are the ones that did not successfully form organoids, but we've had pretty good luck doing this in our lab so far. So the next question I wanted to ask, because collaboration is so critical, is could we expand this biobank for both metastatic samples and also external collaborator samples? And so we've successfully done that. We now have 8 metastatic samples, 6 from the liver, 1 from the lung, 1 from bone. And we have 2 formal collaborating centers, Wills and University of Iowa, but we also have a protocol that allows case-by-case sample donation from anywhere nationwide. So we've had patients who specifically want us to study something on their metastasis that they will send us for generation of an organoid. And we've had good success having these samples that get shipped overnight generated into organoids. The success rate is really similar to when we're doing it in our lab. So I thought initially maybe this was that, less than an hour time window getting these samples to the lab, but shipping overnight we still seem to do just as well. So how do these grow, and what are the morphologic features of the organoids? We see that these become more discrete pigmented structures over time, then they sort of take on their own morphology. They're a little individualized, but then they retain that over multiple passages. They do have some resemblance to the histopathologic subtypes that we used to talk about, the spindle mixed and epithelioid. And then we always confirm these again with melanase, OX10 staining to make sure that we don't have contamination in our samples. And we have a variety now that have their own unique personalities and morphologies. Importantly, for how good of a model is this, is how do these compare to the primary tumors from which they were derived? And at least on the critical mutations that come out of the clinical DecisionDx-UM-seq test, we've been able to compare that these do retain same mutations. We did whole exome sequencing, so we were able to get these from that. The BAP1 splice site SNVs we do have to find by PCR resequencing. They don't seem to come out of our whole exome sequencing test. So we can see that here in table form, they really do retain all the same mutations, and we've seen that over passaging as well. BAP1 status, we seem to retain compared to the primary tumor, BAP1 retained versus BAP1 lost. We have excellent correlation there. And then similar to TCGA data, we see global differential gene expression just divided simply here for BAP1 retained and BAP1 lost samples. And we'll have more of this as we continue to sequence over time. And if we just want to dig in and look at, many of these patients had the gene expression profiling test, and this is that 15 gene panel, we again see the BAP1 retained, BAP lost stratification. These patients tend to stratify out similarly to what their prognostic test result would have been. And then the nice thing is I have clinical data on all of these patients, and our collaborating centers also send me clinical data, so then we can go back and validate and correlate and see how the patients are behaving and actually get paired metastatic samples too from our patients. So can we use these for drug screening? We've developed a 96-well platform for drug screening. These are a few drugs that have been known to use, and someday I will show hopefully exciting data on drugs that we don't know yet. But this is GNAQ inhibitor, crisinostat, HDAC inhibitor, and you can see differential drug response in different organoids, and then trametinib, a MEK inhibitor, which we know doesn't work well in the organoids. And I think this more accurately represents drug response than 2D cell culture, where we often do still see a response to MEK inhibition. So I'm hopeful that these are going to be a much more representative model. And then really where I'm trying to learn and hopefully discover something new is in epigenomics. And we've been able to do a little bit of ATAC-seq on a small subset of 5 samples so far. And again, just dividing them by BAP1 retained versus BAP1 loss, we see differential accessibility of chromatin peaks. And we've been able to dig in and potentially find some targets, specifically looking at PI3K pathway. We found differences in chromatin accessibility to promoter regions of IGF-BP7, and we're able to correlate that back to RNA-seq data that shows they have differential gene expression of IGF-BP7. And then indeed, we have differential drug response to 2 different PI3K inhibitors that tracks nicely from ATAC-seq data to RNA-seq data to drug response data. So hopefully we're really going to be able to use these to do hypothesis generation, discovery science, and get treatments that can ultimately hopefully go back even more in real time to our patients. So I'm very excited now that I've been able to expand this to a multi-center effort. I'm excited that we have paired primary and metastatic samples. It's great to see that these retain features of the primary tumor, so hopefully these are going to be more representative of human disease. And I'm excited to see what we can do next, and hopefully we'll make a big impact for our patients. And I wouldn't do any of this if I didn't have these wonderful people, and especially Martin Fernandez-Zapico, who's a pancreatic and GI cancer researcher in the Mayo Clinic Cancer Center, who's taught me everything I know about organoids and epigenetics and all of that. I'm learning and every day getting a little better at bioinformatics. So thank you so much.
Get some time for questions?
Yeah, any questions from the hungry group of you? Questions? Yes.
Dr. Mahajan, I really enjoyed your presentation. But just to get our head around all of this crosstalk and that kind of stuff, from prior knowledge in olden times, we say there is local immunosuppression going on around the melanoma. Is that what your data also indicates?
Yeah, so we can find those proteins that are part of the immune system and how they're different from plasma, and also how the how the eye changes after melanoma. The immune checkpoints that I showed are really, really specific to within the tumor microenvironment, and feed the concept of how is that tumor able to avoid the immune system, or why aren't the T cells attacking it? So I think it fits with what you're thinking about.
I think another point to that, Arvind, is that if not local tumor immune suppression, there are clear categories of tumor T cells that may be a target, right, that we could think about. And whether that's coming in and infiltrating and modifying differently, that's something that we're seeing now in so many other cancers, and it's the source of billions of dollars of therapeutics specifically looking at those tumor T cells. So it's it may get to your question to answer it, but it may not be just immunosuppression, it just could be alteration in the immune environment.
But is it reasonable to target that in the meso environment when we don't know if the meso environment is equivalent to the distant metastatic environment? And is it reasonable to use that in targeting?
Well, so we haven't looked at metastases and what's happening out there, but I'm suggesting the idea that there's different kinds of signal that's not actually exclusive to the microenvironment that could potentially be targeted to enhance. So I'm not sure if I answered your question. It's quite possible the signals are completely different, once the tumor cell has escaped and it's sitting somewhere else in the body. But I do think it's an interesting signaling event that could potentially be targeted. I don't know, Prithvi.
The other thing that we've all been talking about is neoadjuvant therapy. So, if we're talking the step before metastasis and we're looking for better neoadjuvant treatments, maybe it's a combination of not just direct cytotoxic, but also modifying some of these other cell types that are there as well. So it may not be single agent therapy, multi-agent therapy that still fits that neoadjuvant concept. So, yeah, maybe.
So do you, thanks. So I was curious, do you think that the vitreous will be a better fluid pocket to biopsy for uveal melanomas than the aqueous?
So we used to do a lot of vitreous biopsy proteomics because you need more fluid and more protein. Depending on you can't really do mass spectrometry on aqueous because it's so small, so you have to use a different platform, Olink, we use SomaLogic. When we use our platform, the SomaLogic platform, the difference between vitreous and aqueous was surprisingly very little. So there was probably 600 proteins that were in the vitreous but not in the aqueous. So for specific things of whatever you're trying to look at, you can probably get away with aqueous for a lot of stuff. You can't really do phosphoproteomics in the aqueous, but for things like prognosis and diagnosis and those kinds of things, that's that level of detail is probably not necessary.
Are you guys getting a good nevus versus melanoma signal? Like, are you at the point where you feel really good about saying, like, this is our strong signal?
Yeah, so I think as somebody said, as a clinician, you're like, I know this is a nevus. And I think, maybe that's, 95% of the cases or something, but there's always, we're always aiming for 100%, and then you find these indeterminate lesions, and could you catch something earlier rather than waiting for it to grow massively? And so we've looked at nevi. That's very easy to distinguish from melanoma, and then we have a few indeterminate lesions that you can distinguish. And most of everything that we've talked about and presented is sort of conventional biostatistics. And when you then apply a machine learning algorithm, that's another level of being able to distinguish those things. But I imagine that we really could achieve that. And then, as you mentioned, you could actually prospectively monitor these patients instead of trying to stick a needle in them every 6 months or a year or whatever.
Lauren, I have a question for you. How much cells, like what do people send to you?
My instructions are to do a 20 gauge core biopsy. We can grow an organoid from a relatively small amount of samples. These are from a nucleated specimen, so it's after an eye's already been removed. It's safe, no risk to the patient. And same thing with metastasis. So, if you spin it down in a little tube and you get about this much, we can probably grow.
How many 96 well plates can you make from a 20 gauge biopsy of organoids?
Good question. I haven't done it that way. We wouldn't start in a 96 well. Usually we would kind of grow them up and get a couple passages and freeze them back before we take them to a drug study. So most samples that we start, we will split them in half and we'll do a 2D cell culture in case I lose the organoid, so I still have some sample, and then we'll do the other half in a 6 well single well.
And they grow forever like a cell line? So you can make an infinite number of organoids?
So far we have, I think our highest organoid passage is 22, so we don't know the upper limit yet on passages.
And do you start to interject all new alterations at passage 22, or are they pretty stable?
It's a good question. Morphologically they appear stable, immunohistochemically stable. Need probably an R1 to continue to sequence to know the other answers.
You got it, girl. It's coming.
Are the size, which might imply the melanoma was there longer? Are there senescence issues or necrotic cells that come into your 20 gauge biopsy that influence how this organoid looks or behaves or responds? That would be the other question. How the age or the nature of the tumor itself defines how the organoid either survives or behaves.
Yeah, I think, definitely there have been some of the samples that have not successfully generated organoids, or some that have taken a long time to really take off, came from tissue that seemed much more necrotic. When we spun it down, there was just a lot of necrotic lysed pigment that wasn't cellular that washed away. And so those, I think, are the ones that are highest risk for organoid generation failure in general when you have a more necrotic tumor.
One of the points I wanted to make with Arun here is how do these companion diagnostics that we're talking about here influence or play into your retinopathy trial? Like, which of these sound attractive to try to collect, and how would you use that information in a prospective trial?
I'm glad you said that. So this is going to be a study of 600 patients. And DRCR network will support ancillary studies. So these are not trials, but ancillary studies. So if you wanted, for example, aqueous samples, not all 600 cases perhaps will be included, but you could easily have 3 or 4 sites who are certified and get an aqueous sample. And DRCR will pay for even shipping of the samples, storage of the samples. You're looking for ctDNA, you're looking for any of the biomarkers. So there are a lot of possibilities of doing these other ancillary studies, but only if you enroll in the first main trial. No ancillary studies without the main trial.
All of this is fascinating. Thank you for your presentations. It's very complex, and you've got people with great labs doing interesting work that probably shouldn't be replicated in every center. So I wonder if people would talk about, how do we decide how many centers? Are we going to have 2 or 3 centers only? As a community, do we decide to do that so that you've got some standardization? And do we have anything that would represent criteria? I realize that the different tests get different answers, but within your own test unit, what do you think is reasonable? Because I can't imagine everybody doing it, but to not do it will soon be flagged for patients. How do we make this go forward in a useful way?
Kate, you always ask hard questions, which I love about you. I think it's hard, in such a field where we have so few patients spread over multiple centers. You've all heard me say it for RB. I'm going to say it again for uveal melanoma. I think collaboration is key. It's the only way we're going to get the numbers. But collaboration is really hard. I'm much further ahead in my RB collaborations than I am with my Things get so stuck in contracting. Lauren wants to collaborate with me, and her university won't let her. I can't collaborate back. It's like there are so many university-specific rules that as much as I could stand up and say, I think we have a validated clinical test for the aqueous and RB. So what are you playing at? Send it to us. I can say that all I want, right? It's validated, it's approved, we bill your insurance. If another center won't let a person send to us, then they can't. And frankly, a lot of centers now, I'm not getting their data because they're just sending the sample for the clinical test. So I don't know about it. It gets run by the clinical lab and the report goes back to the physician. I will never capture that data, and the reason for that is all administrative and bureaucratic. It's hard.
Jesse, I'm going to challenge that just a little bit and say that for the sake of the patients for whom we're meant to be advocates, how do we feed back into that system? How do we, as the treating physicians and clinician scientists, feed back into the system that says, wait a minute, we have to have a way to collaborate? And Andrew, your group looked at this for RB internationally. How do we access that system rather than saying, well, we can't because we're being prevented? Because the patients are going to start on that really soon. They're kind of aware of all this data.
Yeah, I agree with you. The question, though, is really how do we, as a non-lawyer, beat a lawyer? That is what it is.
Corporate lawyers, they're the worst. Corporate lawyers. We have this frustration all the time, and I really don't want to argue with corporate lawyers because that's the worst thing you can do in a day. But that's what it comes down to.
That's true. I'm not going to take up all your time, but I will tell you that because I work at an adult hospital and a children's hospital, I literally have a document that a lawyer made me sign that says, Jesse Berry, my USC email address, promises to not share clinical data with Jesse Berry, CHLA email address, because I can't, of course, share the patient's name. It's only coded. Well, how do I not share with myself? That's how ridiculous we are, right? I have that document. Anyone wants it, I'll share it. I'll share it.
So I'm just curious, With all the work you've done on aqueous and proteins, do you have a vision on when that goes live in the real world and is a validated test? Is it 5 years? Is it 10 years? And I'm not going to hold you to it, but you know where you are in the field. You know the data that you have, and you can see already what correlates and what doesn't.
Yeah, so I think, so I'm optimistic that if there is a new test or, ophthalmology pushed AI through the FDA. I'm part of a FDA committee that they've expanded this advisory committee, and I'm trying to move proteomics onto that committee. There are other fields that have solved this, not fully, so it's not like doing a troponin test in the ER. But cardiology, there's Alzheimer's, blood-related proteomics tests have come out. They've kind of moved it through. This is not a laboratory platform, so SomaLogic and Olink are commercial platforms who are very motivated to commercialize their technology. And they're not necessarily in the eye, but I've met the company, and usually they run like 1 billion samples on blood, but they are really engaged in the uveal melanoma data that we showed them, and so they said, yeah, we'll run a few samples, even though we at a little bit of a loss to their profit. So I'm optimistic about that. Because some of these platforms have already made their way through the FDA, and as Jesse said, it's not a CLIA lab test, but it's a medical test, and before a medical test, you can have a research test, and so you just kind of push through those things. I think the patients are engaged. I think ocular melanoma community, going back to the COMS trial, is an amazing community for actually scaling out and expanding. And I think being in the cancer world, I think that clinicians can integrate a research test. We've done that for some of the retinitis pigmentosa patients where we've done proteomics on their eye, and we're able to deliver a research test, to their physician, where we tell them, hey, this isn't a real test and you can't make a full clinical decision, but it's actually unethical to withhold that data from the patient and stuff. So I imagine in the sphere of some kind of clinical research test that we could offer this soon and address some of the like indeterminate lesions, and different platforms can play out, and whoever wins is fine. And like many things, there's probably a couple platforms will probably be okay and meaningful.
Dr. Dalvin, I just had a quick specific question for you in regards to the organoids growth. So I'm at Jefferson, and we work a lot with these uveal melanoma cell lines. During my PhD, it was painstakingly to work with them. But we noticed, as others had noted, that BAP1 loss cells tend to grow slowly, more slow than their counterparts. And we've seen with people trying to knock out BAP1 or do siRNA, that those cells would either never grow or just grow very, very, very slowly. So have you noticed any difference with the behavior of the organoids with BAP1 loss organoid or BAP1 loss derived patients?
Yeah, when we first started, I suspected the cell lines that the BAP1 loss were slower growing. I think we've actually gotten better at growing these organoids now. And that's not always the case anymore now that I think we've honed our skills. And we actually, of those 40, more than half of them have BAP1 loss. Dan said we need animal models. Someday I'll show you the data. We can grow them in a mouse animal model as orthotopic xenografts, and we can grow native BAP1 loss organoids in the mice.
Andrew, did you have a 6-second question? That went from 6 to 0 fast.
Oh, it's already over. We as ophthalmology and ocular oncology are the original crowdsourcers of ophthalmology. One of my favorite reviews to read, this is a letter to the editor, is hopefully there's not somebody in this room who wrote this, but back when COMS was made, before my time, there was this letter to the editor saying, this trial, it's to a main journal in our field, this trial's never going to get off the ground, it's never going to happen because you don't have the most important people enrolling patients. I love this editorial because, of course, the COMS is great study. We don't need everybody, and sometimes, Lauren and Jesse are not going to be able to collaborate because of your universities, but we can get most people, and we can crowdsource this stuff, and it works. You guys have both shown it just works. We just have to be optimistic about it.
So I'm going to talk to you to share a little bit of some unpublished data with you that I wanted to present. Basically, I've had a unique opportunity. It's not super unique, but I've used different plaques over my career, from starting with Paul Finger and using some plaques, to moving to the Shields and having their plaques, to moving to Memorial to use Com's plaque. And this is my 7 years of experience with the iPhysics plaque. And during those times, I noticed that like all plaques I assumed were supposed to do the same thing and respond similarly. But in my anecdotal experience, there was a definite difference in all the different modalities that I used. And I had about 7 to 10 years in each place to kind of get that feel. So I wanted to look at this group of patients, and these are my iPhysics plaques since I was at Columbia from 2017, and I wanted to have at least 30 months of follow-ups, and it resulted in only about 139 patients. I was like, well, why is that? And I think that we excluded those patients that didn't complete follow-up, those that passed away, or those that didn't have a significant follow-up time. But they're all done by the same place with the same technique using the iPhysics. And we basically collected the data as we normally do. The basal diameters and the tumor thickness was measured with ultrasound and clinical exam. And we used 85 gray to the apex as our dose. And we used it over 72 hours and had a 2 millimeter margin. And we also used the iPhysics three-dimensional treatment planning and surveilled patients with CT or MRI. And we checked them every 3 months for the first year, every 6 months for the next 5 years, or 4 years, and then after 5 years, we checked them once a year. And the demographics were pretty standard. Mean age was 63. There's equal male, female. The starting visual acuity was about 20/40, and we kind of like 70, almost 71% of patients had pretty good vision, or 20/40 or better, and then moderate and worse vision were in the other 30%. There was a high, as I mentioned earlier, there's a high concentration of choroidal tumors. Almost 90% were choroidal, 2 ciliary and 9 ciliary. And I think that may be because maybe my ciliary body patients had bigger tumors and either were enucleated or passed away before the end of the study. The mean tumor height was 4.8 millimeters, and the mean approximation to the optic nerve was 4 millimeters. And the average plaque size was about a 19 millimeter plaque. And so we looked at dose. And so my goal of this study is I wanted to kind of incrementally assess dose to vision. And I struggled with this because of the numbers, but basically we took each important structure like the optic nerve, the macula, the opposite retina, the lens, dose to the apex, and calculated the dose, and then tried to correlate that with visual acuity. The mean visual acuity at the final follow-up was 2200, which is pretty poor. 37 patients had good visual acuity, or 27%, so a third of that 70% that started with good visual acuity had it. And then 50% had worse than 2200 vision, and 50% lost at least 5 or more lines of visual acuity. And so we use these markers as loss of 5 lines and 2200 or worse visual markers as a surrogate for acuity, and related that to dose. The other thing is that during that period, there was no recurrence, and 100% of patients had no recurrence, but we did see at least 80% with radiation side effects. So what we did is we took those visual parameters, i.e. loss of 5 lines or more, or 2200 visual acuity or worse, and looked at the structures individually and divided the dose range of those structures that they received in the treatment planning and segregated them into a low, medium, high. And then we looked at what threshold or time did 50% of those patients meet that criteria, i.e. loss of vision worse than 2200 or loss of 5 lines. And we saw that what we would expect, that the critical structures, the more radiation they got, the worse the visual acuity they were, and there was significant changes related to dose. And what we were trying to backpedal from this information is how much dose would we need to reduce to get patients to have a 50% chance or greater of having better than 2200 vision or better than 5 lines of visual acuity loss. And if you look at kind of how we broke it up, radiation to the center of the dose, if we had a dose of 27 gray or less, 53% of patients did well. And then if you look at fovea dose, it was less than 35. Radiation to the opposite retina, which was kind of interesting, less than 9 gray to the opposite retina gave you a good visual response. Base dose to the sclera wasn't super significant. Radiation to the tumor apex, and I found this interesting that the less dose that you have to the apex, the greater chance that you have for better visual acuity. And I think that's something interesting with eye physics plaque, because if you look at the range that we had in tumor apex dose, it goes from 91 to greater than 117. And our prescription dose is supposed to be 85. And so the reason that happens is because to cover the entire base with the proper dose, they have to pump the apex dose. So you're actually getting more. And maybe that's the reason my recurrence rate is so low, is because we're really over-treating these. And so what we're trying to see is if we find these incremental dosing shifts that we can substantiate, and if you look at those curves, you can extrapolate reducing doses to certain structures by a certain amount, we can save a proportion of visual acuity. And that's important these days because now we have ways to either adjust the dose, or with neoadjuvant treatments, we can shrink the tumors to obtain these doses and know we make a significant impact on the visual acuity. I was kind of disheartened that the amount of data that I had couldn't get me the actual answer that I wanted, which is if you reduce the dose by 10 gray to the fovea, you're going to have 20/50 vision. And I think it would be nice if we got more data involved so we can actually have kind of this incremental dose to vision correlation. Thanks.
Do we have to wait till the end for the questions?
We will
Yes.
wait till the end for the questions. So next is Miguel Matarin, talking about dose reduction for radiation therapy. Are we ready for a clinical trial?
Thank you, and thank you, Priti, for the invitation. And I think that nothing better for my presentation than having Brian speaking before me with that topic. I think that this is a continuation of what he presented. So the title is Dose Reduction for Radiation Therapy in Uveal Melanoma. Are we ready for a clinical trial? And the answer is yes. And I still have 10 minutes or 9 minutes to finish, so I'll continue. And I think that disclosure should be complete, not only financial. I think mental should be also disclosure, and so you will know who's presenting here. So these people with Mexican hats, that's in Sydney, Australia. This is how crazy this is. Anyway, so these are my disclosures. I have nothing to do with this presentation. And we cannot talk about brachytherapy without mentioning who was the first one, as Dr. Staller from England, almost 100 years ago. And a lot has been going on since then. We all know about the COMS and with the 3 arms and the conclusions. Tumor control, excellent, 90%, that's good. Globe preservation is also good, almost 90%, but need to do better with vision. And there are several publications about reducing the dose for this treatment. Please correct me if I'm wrong, Arun, but I think that the COMS, the 85 gray, was decided within a group of people with no evidence, right? Was that?
Empirically derived.
All right. So, and there are different groups who've been trying to reduce the doses and to treat them, without leaving or increasing the risk for the patients. And then on the people at Duke, before I came on board, they published this paper that basically from 1988 to 2010 using COMS-PLAX, 190 patients, and the dose was between 60 to 85 grays to the tumor apex. And then we published our initial 69 patients using the eye physics, but it was a different way of calculating the dose. It was 63 grays to the target volume. What does that mean? I'm going to show it to you. So currently, we started in 2016, we're using a three-dimensional treatment planning with eye physics simulator, and the goal is to deliver a minimum of 63 grays to the tumor with a 2 millimeter circumferential margin at the base and the apex. Basically, it's 63 here and 63 to the apex. That's the goal. And because of not all the tumors are the same, sometimes the apex will receive more radiation than we expect, and sometimes will be 85 grays or more. So I'll show you some examples. These are the preliminary results. The statistics are not completely done. My partner, Dr. Maniar, she gave me as much information while we are processing all the information. But in general, as for now, we treated 426 patients, and we excluded 26 because they didn't have enough follow-up, or they're less than 6 months of follow-up. The local failure was 4%, 16 out of 400, and mostly was related to tumors that were close or by the optic nerve. Enucleation, 5% of the patients in enucleation, 6 of them due to blind painful eye. And distant metastasis was about between 12 and 13%, 49 out of 400 patients. Visual acuity at presentation, the mean was 20/40, and at last visit, the mean was 20/80. So I don't know if that correlates with what Brian was saying, but when you said that 20/200, we're talking about in general 20/80, that looks promising. Some examples. A large uveal melanoma, you have the fundus, the fundus image and the ultrasound. So the red line, I don't know if you can see that, but there is a red line that shows the 63 gray on the picture on your left, and here to measure to the apex. And you can see that this patient, the apex received 70 grays. That was the before and the after. Another patient. In this case, once again, the red lines represent the 63 gray circumferential and to the apex. But this patient, the apex received 86 gray. So it depends on how the simulator calculates the doses, how we're going to see here. And that was the after the treatment. This was interesting to us. This was a patient with a history of optic nerve melanocytoma that showed some growth after some years. It's not a surprise that it was a non-aggressive tumor. We did the plaque brachytherapy again, and at 63 gray circumferential, and this patient received to the apex 63 grays. And that's the after. And this one, I wanted to share this patient with you because of the almost circumpapillary, how ugly it looked, and 1 year later, the good response. So we currently are enrolling, we have this study, it's called Prospective Registry of Ocular Melanoma Patient, or PROMPT. It's a registry study. The goal is to follow patients prospectively to investigate local control, visual outcomes, and metastases. And when I presented some of these data last year in Cleveland Clinic, they were like, well, but you have your 400 patients. Why do you need the prospective trial? So I don't know. I said, well, I don't know why you need that, but we're doing it. At least we are doing the registry. For now, it's a single institution study. It's at Duke, but we are open to become a multi-center study. And we have the connection who you need to contact to if you are interested in participate in this. And again, we want to compare the outcomes following the plaque brachytherapy with the institutions, each institution with the standards and protocol. This is our team, Dr. Maniar, who's here, the radiation oncology team, who are always willing to help us. And that's it. Thank you so much.
Okay, next is Ivana Kim talking about Belsar Phase 3 and beyond.
Great. Thank you to Prithvi for the kind invitation. It's really an honor to be here. And I guess I'm talking about the ultimate in dose reduction, right? That's the motivation behind developing this treatment. So I think many of you are investigators in the Belsar program, so I don't have to introduce you to this drug. It's a virus-like drug conjugate in which the viral capsid has specificity for malignant cells, and it's conjugated to a photosensitizing dye, so the drug can be activated by laser, the same laser that we use for PDT currently, and that results in tumor cell necrosis and possibly a secondary mechanism of immune-mediated tumor cell killing. So recently, the results of the Phase 2 trial of Belsar for choroidal melanoma, where the drug was given by suprachoroidal administration, were released, and it was an open-label dose escalation design. And I think the take-home message is that the therapeutic regimen ended up being 3 cycles of treatment, so 9 times the patient got an injection of the Belsar followed by 2 laser applications. So several weeks of treatment, and the endpoints were tumor progression, shown there, either growth in thickness or in large basal diameter, as well as visual acuity and change in tumor thickness growth rate. So looking at control of the tumor with respect to those patients that did or did not meet the defined endpoint of tumor progression, we can see that 80% of the patients that received the therapeutic regimen had tumor control at 12 months, which was the endpoint of the study. If you look at tumor growth rates, you could also see this was analyzed in patients that had documented growth prior to study entry. And you can see essential cessation of growth among those who received the therapeutic dose and were considered responders. In terms of vision, visual acuity was preserved within 3 lines of baseline in 90% of these subjects receiving the therapeutic regimen. And the Phase 3 eligible refers to the fact that 1 patient with a circumperipapillary tumor who would not be eligible for the ongoing Phase 3 study was excluded from these analyses. So, as you know, based on these promising Phase 2 results, a Phase 3 study is currently enrolling, and the study schema is shown here. It's a 2:1:2 randomization, 2 with the full therapeutic dose, 80 micrograms of Belsar, a cohort getting a lower dose and another cohort getting sham. And the endpoints are slightly different. They still involved tumor progression and visual acuity, but they're analyzed in a slightly different manner with time to tumor progression or time to the composite endpoint. So if you look at the Phase 2 data presented in that way, there's still a highly statistically significant benefit to the Belsar treatment versus those who received the therapeutic dose versus the subtherapeutic dose. Obviously, in the Phase 2, there's no shams. So they're also looking at the application of Belsar to metastases, and this Phase 2 trial is in study startup and expected to hopefully enroll like any week or any month now. It's a limited cohort of patients, also a dose escalation design, and it's first limited to patients with unilateral and unifocal metastases. only from breast or lung primary. So a very preliminary kind of early exploratory study for a different indication. So really the purpose of this talk is to speculate about how we're going to use Bel-sar in the real world. We hope that the phase 3 study is going to be similar to the phase 2 results. And presuming that it is, I guess, some audience participation or panel participation might be welcome here too. I feel like probably the place where it's going to make the biggest difference may be these indeterminate lesions. We were kind of perseverating earlier in the session about when do we decide to treat indeterminate lesions, and part of why we have this dilemma between treating and non-treating is because our current therapies have such visual morbidity. So if we had a treatment that could preserve vision, would we treat most or all indeterminate lesions? And would we, I think you're going to hear from Ezekiel about using GP to maybe make treatment decisions, would we need to kind of incorporate that strategy if we had this treatment that theoretically is vision preserving? I feel like I would be using it more in these indeterminate lesions close to the fovea or the disc. What about recurrences? These are two patients that I'm struggling with now. Recurrences after plaque treatment, basically involving the fovea and the disc. They have excellent vision right now, and they have not wanted to pursue additional radiotherapy because it would mean significant loss of vision. Will we be able to use Bel-sar for these situations? Well, maybe the initial tumor was not necessarily the type that would be enrolled in the current studies, but a recurrence in the macula or near the disc might be a good indication for. What about small melanomas? Is 80% tumor control, is that convincing, 80% at 1 year? What if it drops down after, to lower than that at 2 years and 3 years? Is that acceptable to the community? And again, will GEP play a role? Are we more likely to treat small melanomas that are GP1A or GP1 PRAME negative with this treatment, and treat the more aggressive ones, aggressive class 2 tumors with radiotherapy? I don't know. Expanded indications. Currently, the upper limit of thickness is 2.5 millimeters in the trial with the largest basal diameter of 10. We could probably treat slightly larger basal diameters. Are we willing to push the thickness limits after we know the efficacy profile of this drug? And what about metastasis? It's somewhat unusual to see unifocal metastasis in one eye. Would we push it? I think in the bottom photo where there's numerous metastases, I'm not sure that would be a great candidate, but maybe if the other ones are small and the most visually significant one is in the macula, maybe that would be a temporizing measure. And are we willing to stretch the indications to other primaries other than breast or lung based on the results of the initial trial? So I'm happy and I welcome all the experts' input, I guess, during the panel discussion, but I think just like we've modified treatment regimens for anti-VEGF therapies after the pivotal clinical trials, I think you're going to see that we're probably going to modify the treatment regimens for Bel-sar afterwards, because 9 cycles is quite a bit for patients. Are we going to do 3 treatments per cycle? Are we going to do 3 cycles? Are we going to wait only 1 week in between the cycles? In some of these indeterminate lesions, are we going to try to get away with fewer cycles or fewer treatments per cycle? Or are we going to push the limit, and if there's some mild growth after the 3rd cycle, are we willing to push it to a 4th cycle? I think there's more questions than answers at this point. I think there's much more beyond phase 3. Hopefully, as it gets through phase 3, we'll be able to utilize it as another tool in our toolbox. We ocular oncologists as a group need to help refine the clinical indications and treatment protocols. And clearly, longer-term follow-up of trial patients is essential to really determine the optimal role of this treatment. So thanks very much.
Okay,
I think we need a whole day off for discussion on this topic, but.
Lots of good discussion to be had after our last speaker, Ezekiel Weiss, on early biopsy and treatment observation decision analysis.
I think this ties in nicely. So in our center, we do use fine-needle aspiration biopsy to guide treatment of the indeterminate lesions when they're in a specific location. This is a group, as Jesse pointed out, of really very experienced people. And so I wanted to provide some new information in terms of the way I think or we think about things in Alberta. And it opens things up to questions and criticisms of what we do, and maybe we can learn from it. It's no financial interest that we're late, because I get no money, even though I'm on the advisory board for Castle Bioscience. So I'm going to go over just some basic definitions, recap some of the pessimistic viewpoint, and then go over kind of a decision analysis approach, all in 10 minutes. So we know there's a spectrum of a freckle from a non-malignant potential to a low-risk nevus all the way to melanoma, and we also know melanomas now are both low risk to all the way to high risk. We know that the risk of growth and metastasis increases as we move along this spectrum. Clinically, we're usually quite good at identifying the cell of origin in a classic case, about 98% accuracy. We're good at determining the size, and if it's a small lesion, then we're pretty good at identifying the lesions, the risk factors, depending on which risk factor profile you like using. Therefore, we're good at lots of things, but we cannot differentiate a small melanoma and a high-risk nevus on the first visit using standard testing that we use, and therefore many of us use the term indeterminate melanocytic lesion. We are aware of, we talked about class 1, class 2, PRAME positive, PRAME negative. I just quickly want to discuss the genetic mutations that lead to this. I believe we're moving towards the standing that from a melanocyte to turn into a nevus, we have a G protein mutation, which allows for cell replication, but without the ability to spread or metastasize. And then a second order mutation in either the EIF1AX, SF3B1, or BAP1 is required for the nevus to turn into a melanoma. If this is true, then we have an opportunity to use the assessment of these mutations to help guide treatment. Another way of seeing it is you have a nevus, which already has the G protein mutation, and then the second order mutation will take us to anywhere from low to high risk lesion. So I'm going to quickly go over this busy slide. It has to do with a pessimistic viewpoint, because if you believe in the pessimistic viewpoint, which means we don't alter outcomes, it doesn't matter if we treat now, it doesn't matter if we treat in 3 years, then what I'm saying doesn't make sense. So I'm going to try to provide some evidence to disprove this. So what is the pessimistic viewpoint evidence? If you look at research studies that try to state when the metastasis occurred, it often says it happened prior to presentation. But if you read the fine detail of those studies, you can see it was prior to the lesion being labeled a melanoma, rather than when it was first detected. That's quite different, because many of us will see a small lesion, watch it for years, it grows, then labeled a melanoma. And that's why this tumor doubling time, these studies trying to pinpoint when the actual metastasis occurred isn't necessarily accurate. In addition, they assume linear growth. And it also negates the basic principles that we understand in every other tumor, and now also in uveal melanoma, that you require a sequence of genetic mutations to reach a tumor that's metastatic or dangerous. It is not a single point mutation that happens on day one, and then from that point on it's a dangerous tumor. So why is the pessimistic viewpoint incorrect? Tumors grow over time. We all know this. You can't have a tumor that has metastatic potential that doesn't grow. And every single study that had adequate power showed that tumors that are smaller have better survival. Every tumor study that had adequate sample size showed that genetic mutations were related to poor outcomes, were less frequent in smaller tumors. And every adequately powered studies that followed tumors over time and treated them after growth was detected showed a poorer outcome. The studies that showed it is safe to observe, in my opinion, they're all underpowered with either inadequate patients or time, and that's why they said it was safe to observe. Are there tumors that we would clinically label a melanoma but are actually a nevus? There are, and therefore obviously it's safe to watch those. So our labeling varies between groups, but if it's an actual melanoma, I don't believe there's research showing that it's safe to watch. When it comes to the final comment, there's a ceiling effect. If you look at cutaneous melanoma, and there's a graph there up there with a Breslow thickness. Once you get above 3 millimeters, survival is the same. And if we're using 3 millimeters in the eye, I know it's similar, but it doesn't really matter that they match up, that we weren't treating tumors until they're 3 millimeters, then of course we're not going to show improvement in survival because we've missed that opportunity, we missed that step. So the ceiling effect, I think, came into misguiding some of the earlier research. So when we see a patient with indeterminate lesion, we have to take multiple things into account. What's the chance this is a melanoma? What's the significance of the treatment in terms of vision loss, and what's the benefit? And using standard cytology, which is kind of the predecessor to what we use, focusing on gene expression profile, can be criticized because many cytologists and many pathologists will tell you that yes, you can attach a label of this is a low-grade melanoma and this is a nevus, but the evidence behind that distinction isn't strong. And it's very difficult. One cytopathologist will say one thing, and another cytopathologist will say something else, making cytology difficult. So I'm just going to quickly bring in decision analysis and get to the meat of this. So decision analysis is a way for us to apply the knowledge that we have to make difficult decisions, and one of the most common terms we use in terms of emphasizing is the quality of life year, which basically means the quality of your year multiplied by the number of years you have. And so here is a decision analysis tree used for a lesion in the breast, about whether we biopsy, whether we observe, and it has nodes and decision points and probabilities, and it allows you to pick the point that's the most logical or the best to use. So I'm going to apply a very basic version to what we know in eyes. So let's assume that for the purpose of this discussion, we're going to use a 40-year-old female who lives in a country with the average life expectancy of 85 years, and she presents with a small, high-risk choroidal melanocytic lesion or indeterminate lesion. If you observe this and it never grows, then this person has 45 quality of life years ahead of them. If you observe and grow and then you treat them, then they lose vision a few years later, but they have a higher risk of metastasis, so they're just throwing a number out there, they have approximately 30 quality of life years. And if you treat at day 1 and it grew, then they have 35 quality of life years. So even though their vision goes down earlier, their years of life are longer. Those numbers these are just for explanations, just to go over. And so because we don't have strong evidence on those numbers, I'm going to use 2 non-controversial examples. So here's a 44-year-old female, and she has a small indeterminate lesion in her peripheral fundus. So let's just assume, based on whatever prognostic tool you use for growth or metastasis, she has a 60% chance of growing and 40% chance that she doesn't grow. The lesion doesn't grow. So we can either treat with plaque at the time of presentation, we can observe, then treat with plaque, and then it either grows or doesn't grow. So you can see that you can attach actual quality of life year to each different sequence. So for example, if the lesion doesn't grow and you observed, we have the full 45 quality of life years. If the lesion doesn't grow and you treat it at the time of presentation, they've lost some vision, they've got some dry eyes, so the quality of life goes down, and so forth and so forth. But because this is a peripheral lesion, the amount of vision loss is so low that when you add up the different treat or no treat options, you can see that treat has an average 43 quality of life years, whereas if you observe, it has 33 quality of life years. So this is a silly example of a very obvious situation. If they come to my clinic with a small, high-risk, indeterminate lesion, we would typically treat because of going through this thought process. If we do the same thought process for something that's subfoveal in a monocular patient, then obviously if you go through these numbers, we all do this in our head. This is just a way of putting it down on paper. You'll see that it makes sense this time to observe because they have more quality of life years, because if you blind a patient with their only eye and there's only a 60% chance this will grow, it makes sense to observe in this situation. So those are 2 examples of non-controversial things that we do on a daily basis. But then it gets much more complicated. We can use treatments that have limited success, like transbutyral therapy. We can biopsy to get more information. What if we watch the patient very closely every 3 months compared to every 6 months? What if Belsar ends up being amazingly effective in this subgroup, and we use that? And we also have to think about risk of loss to follow-up, like the example earlier today that came in 16 months later and the tumor tripled in size. So today, I'm going to quickly talk about biopsy in this role. So let's take the same example. This is a 40-year-old female that has a subfoveal monocular lesion, but she has a class 2 PRAME negative tumor. So we biopsied, it came class 2 PRAME negative. Well, in that situation, there's almost 100% certainty this will grow, and therefore these 3 options are off the table, and we would all treat. I think most of us would treat, assuming the patient will allow us to treat. So this is a situation where the gene expression profile allows you to make a difficult decision. In contrast, what if this is a subfoveal lesion and it's a class 1 PRAME negative? Now all those percentages change based on these red numbers, and then in this situation, it would make sense to observe. So this is kind of how we use it without the hard numbers and the raw data that we actually are collecting in terms of quality of life year analysis to be able to do formal decision analysis. But this is kind of the thought process that we use in our center to decide how to treat these lesions based on vision loss and expected improvements in survival. I think we're out of time, so we'll end there.
So I think we're done with the session. We're now coming to the interesting part, which is the discussion. So for that sake, the first 2 presentations on radiation we'll discuss together, and then we'll discuss the other 2 later. How about that? So any 2 questions? Questions about the first 2 presentations on radiation dose? Are we over-treating? Need to cut down the dose, etc., etc. Anybody has a question?
I have a question. So
comment, sorry.
It gets to Miguel with we've talked about this registry versus a randomized prospective clinical trial. I understand your data and the power of it, but maybe that's not reproducible in all centers. Like maybe there's something different about, you're loading differential seed strength, or how the planning is done, and how the ultrasound is done. So I wonder, will radiation oncologists in general, follow the cookbook from a paper, for example, to say that's enough? So, and Brian, maybe you can chime in as well. What level of evidence do we need as a community, and also to convince our radiation colleagues to treat lower?
So my answer to that is very simple. You and I can sit here and try to come to an agreement about the seats, the ultrasound, what patients were going to this way. And if you multiply that for the amount of people who are in this room, let's say from 15 different centers, I think it's almost impossible to find that. However, if we set somehow a way that giving some freedom to each center and how each center does things, then we may come with an agreement. I don't think that we can do a generalized, very compact way to make it happen. That's more or less how I see it. I discussed this with a radiation oncologist, and they said, well, why do we need to do the same thing that we already have done? And she said, well, it's a different way of doing things. I don't know if randomized will be the way to go. Honestly, I don't know the answer to that. So, but I think that every center has enough evidence about how they do things.
So can I chime in a little bit? Go ahead.
So just from a practical standpoint, I addressed this with my radiation oncology team, and they wanted evidence that supported the dose reduction so they could follow through. They were willing to try it, but they really wanted some other type of evidence to support that. So I think that there should be something out in the literature in a standardized format that they can fall back onto.
So not quite related to plaque brachytherapy, but Ivana came in proton beam. You have done a trial, haven't you, with 50 cobalt gray equivalent?
Mm-hmm.
Can you comment on it?
Yeah, so we did a randomized trial of 70 versus 50, and the original trial was tumors that were somewhat close to the center of the, either 4 disc diameters from the disc or fovea. And the control was equivalent, although we couldn't establish any significant visual benefit. And I think that, Brian, you're kind of echoing the same type of thing. I think our doses are just so high that it's going to be hard to really prove. I mean, I don't think that dose reduction that we're talking about is going to result in like a very measurable vision benefit. I mean, we may have to try to, do other surrogate measures of radiation retinopathy, and I think ultimately I think it's going to need adjuvant therapy to get better visual outcomes. But yeah.
Thank you.
Just a question, because we looked at the ruthenium 106 plaques, and we were able to use the iPhysics program actually to replace the plaques. So when we knew what the outcome was, and then we didn't have the original calculations, but we were able to put the plaques in and found that that what we thought we actually gave the tumor was not really what we gave them. So did you look into trying to recalculate, when you know the exact placement of the plaque, did we actually provide 85 gray to the apex, or did we not go that? And the other thing was that we figured out that we needed to go much higher, so we are now giving 130 gray in order to have tumor control, because that is a big problem with the ruthenium.
Historically, there's been cold spots in ruthenium, I think probably maybe 20 or so years ago, where at least at Memorial we could map out exactly where the cold spot was on the plaques that we were using, and we verified that they weren't getting the dose that was prescribed. So
go ahead. I'm sorry.
No, go ahead.
No, he hasn't finished.
No, I'm done.
Oh.
Anybody else has a comment?
Well, but regarding that, Arun, when you put the COMS plaques were placed, thinking that they were given 85 grays, that's not true either, because you have the distance from the seats to the tumor, you have the C-elastic, we have other components that I don't think that was accurate either.
No, that was 100 that came down to 85.
Was that?
That was 100 that was corrected to 85.
Okay.
We will come back. Let's finish our comment, then I will add mine at the end.
A couple of questions and then a comment. I don't hear that you're doing any imaging at all on these patients. So there's no fluorescein angiography, wide field angiography, looking at how much ischemia that there is. And I think if we don't look to see what's happening, we're not going to know what's generating the radiation retinopathy. I hear people talking as if the dose to the structure is the only thing that matters, and I think there are multiple other factors. If you look late, you need to almost talk about a zone, like a central, a middle, and a peripheral zone. And so if you put a plaque of the same type on the same size tumor in something really peripheral, the ischemic area is only in the area of treatment. If you put that same thing closer to the origin of the vessels, you have a much broader area of ischemia, and the effects of your radiation retinopathy, I don't mean that it's physically located in the fovea, I mean the amount of ischemia and the factors being elaborated by the living retina are affecting your fovea. But all we're talking about here again is back to just the physics numbers, and I think we're missing the object. And then I also don't hear anybody talking about what's happened to the photoreceptors. And so whether or not you've got ischemia, if there's radiation effect on the photoreceptors closer to the fovea, you're going to have a problem, but it's not measured in this.
We did mention that in my talk. Thank you.
If I can make a quick comment about, I think one of the reasons the higher dose to the apex was associated with better vision is with the iPhysics planning, they treat to a minimum, I think 3.5 millimeters high. So if you're treating anything under 3 millimeters, a tumor, you're going to grossly overtreat that apex, and I think that might be, those small tumors might be misleading that finding.
Also, usually the larger base tumors will get the lower dose to the apex. So that's, you're looking at a much bigger tumor set. So both of those things are factors.
So I'll give my 1 cent comment on this. There isn't any tumor that gets as high a dose as uveal melanoma in radiation oncology. No tumor gets 85 gray. And there's no other tumor that has such a highest control rate either. 99% to 100%. You showed 100%, we can show 99%, so you almost said 90%. So there's no other tumor that gets such a high dose, and there's no other tumor that has such a high control rate. Obviously, we are over-treating, okay? We need to cut down the dose. But also at the same time, we know there's a threshold effect. If you reduce the dose from 80 to 50, there will be no visual benefit because you got to go below 45. Your papers also say that, right? When they looked at the dose of the disc and macula, all the papers say that there's a threshold effect of radiation. So you really, to save vision, you really have to go down drastically as for looking for the vision control, because your threshold is about 40, 45. So I'm not so sure we'll be immediately able to come down from 85 to 45 tomorrow. That's not going to happen. So that's one thing. It has to be a slow gradient, maybe perhaps over many years. Second, between different centers, there is so much variation in the software. Even the versions of the software, the 10 to 15% variation, one should accept that. And the third thing that he pointed out from Denmark, he says, what you plan and what you actually give is also very different. You plan 85, by the time you take the plaque out, how the plaque was placed, there may be so much variation, you may end up giving only 75 because you took it out before 72 hours or you went 85 hours. So the aimed dose is not actually the final delivered dose.
Well, you don't know my radiation oncology team. They are very strict with the time, very strict. And so, but point well taken.
So with that, we close this this part of discussion. We move to the more interesting or more critical part. Oh, go ahead.
To that point, yes, your radiation oncology team is awesome, but like it may not be every radiation oncology team is that awesome, right? And the other thing that I worry is that let's say there's a delay to get a patient to treatment and a larger tumor grows and then it hits less than the threshold. We've crossed that magic line. And then people start to fail, right? So that's the only reason I'm questioning whether there needs to be like greater rigor, multi-center, like all this stuff. I don't know if that's the answer. It's probably a lot of work. But I just worry that like if people say, oh, you know, Miguel's 400 patients, I can just program it there, I think they're going to mess it up. Like I think in general people will mess it up.
Do I have time?
Please do.
I agree. I agree completely with you. And you cannot mimic, I think, what one center does. And that's what I meant when I answered first, when you asked me the question. It's almost impossible to mimic one center to the other. Now, if we are open enough, we are open-minded and see how we can find some points in common, then I think it's feasible.
Okay, for the sake of time, we'll move on to talking about Belsar. Any questions? Yeah.
It's just a comment. We already, Aura's already had press reports suggesting that there's use in bladder cancer. So we already know another malignancy where there's been clinical efficacy in its use. So yes, probably the limitations to the metastatic study are the ones that they chose, but that's to get accrual. But once it is, I'm sure people will use it in off-label use, and there's evidence that there's another malignancy where there's clinical evidence of efficacy.
Yeah. So I think the reason why we in Scandinavia at least become a little interested in Belsar was the comments after the first trial that showed that there was a systemic effect of Belsar. And nobody really touches that one, but I think that is really the most interesting about that drug is if we can induce a systemic response, which basically would remove all the possible micrometastases that are sleeping in all over the body.
I mean, that's what we were alluding to when we say there's this, immune-mediated tumor cell killing, and it primes the immune system to recognize uveal melanoma cells. I think it's been shown in, rodent models, but it's really hard to really prove that effect in patients. But I also feel like because of that potential benefit, that maybe we would be willing to accept a slightly lower control rate, because does failing this have the same implications as failing radiotherapy? You know, where like if we fail radiotherapy, we failed like the atomic bomb. But if we failed this kind of more gentle, local, more specific therapy, does it really mean that we increase the patient's risk of metastasis? We're going to have to follow the patients long term to see. But I think Jill had a comment too.
Hi, Jill Hopkins, I'm CMO at Aura. I did just want to follow up on Dan's comment on the bladder data. We do on our website have the full presentation of recent phase 1 bladder data, and just a couple points to highlight, because you in the ocular oncology community have believed in this mechanism, moved us forward to treat in patients without having histopathologic determination of that mechanism of action in eye tissue. In the bladder, early days, but we saw in 4 out of 5 low-grade intermediate patients that they had complete responses, the tumors disappeared, and we saw immune infiltration, CD4, CD8, and some lymphoid follicles formed not only in the target treated lesion, but in non-target untreated lesions elsewhere in the bladder. So again, early data, but really compelling in terms of that mechanism of action in human tissue. So more to come, but I think to Dan's point, just really fascinating as we start to develop in other cancers. And just to add, the treatment in bladder cancer was ocular volumes, ocular doses, thanks to you, where we developed in tumors 10x the size of what we treat in the eye. So early, interesting, more to come, but wanted to draw your attention to that.
Thank you. So the question about the indication for Belsar, and it's all theoretical, and I get that, but I don't want it to be like TTT. So in 1994, 1996, everybody was treating just everything with just TTT. At the bottom line, it worked well for nevi and didn't work for melanoma. And you were treating don't know what. And if it happened to be nevus, you had good control, and if it was melanoma, it didn't work. So I think one has to be very careful in defining the criteria for selecting patients so that we don't suddenly get too excited, start treating everything, and then find out it doesn't work for these cases and end up abandoning what we learned.
Well, but one more thing, and I agree. When I heard about Aura, I had the same feeling about with the TTT. But I think that what happened at this course between the presentations by Ivana and Ezekiel and the previous sessions, I think that the combination of the liquid biopsies and all the analyses that were shown today combined with the clinical part, and it will help with the decision making. I think things are going to be much safer. So it's not about this session or the other session, it's about the sessions together.
Just a question about the effect on the photoreceptors and all of the retinal layers in the area that you're treating. If we're tagging this to be saving vision, what do you see after a couple of years on OCT?
I don't think we have a couple of years of follow-up on the suprachoroidal patients. On the intravitreal patients, you know, there was a few reasons why it was determined not to be an ideal route. One was intraocular inflammation, and the other was there were some retinal pigment epithelial changes related to the PDT effect on the RPE, basically. But I think with the suprachoroidal delivery, there's less kind of extraneous drug that can be activated in the vicinity of the tumor, and there's less of that pigment epithelial change, but yet, you know, we're doing OCTs on all the subjects, and it's also confounded by the fact that, you know, many of these lesions have subretinal fluid to begin with, and as that goes away, that has an effect on the photoreceptors. So it may be hard to kind of decipher what was, you know, baseline fluid effect versus treatment effect.
Ron, do you have a sense of how deep a lesion Belsar can work? So, you know, that's the issue, goes back to PDT, right?
TTT.
I mean, TTT. Sorry, we had extraocular extension years later, and recurrences probably didn't penetrate deeply enough. So is 2.5, obviously it was picked for many reasons, but do you have a sense of depth of penetration?
I mean, we gradually got to 2.5. So the phase 1, we were enrolling patients up to 3.5. And so then we gradually got to 2.5 because, you know, the phase 1 was intravitreal, and now we're suprachoroidal, so who knows, you know, maybe it's somewhere in between. You know, This is my personal opinion. It's not, validated by or as like preclinical studies or anything. I do think that there's a limited penetration to the light. And so far they haven't shown any differential between pigmented and like less pigmented tumors like we would see in PDT. But it's just my personal opinion that I think that it might work better in less pigmented tumors as well. So I think all those kind of things are gonna pan out as we use it more. But probably the thickness limit is maybe similar to PDT. Maybe we can push it a little bit because of how we're dispersing the drug, but I think there's a limitation to how far the light can penetrate.
Great discussion. Any questions for
So, first of all, I want to clarify a few things. So, nobody says that observe a melanoma. Nowhere, I've written some papers on it, have claimed that observe melanoma. If you can make a diagnosis of melanoma, please go ahead and treat.
I see observed melanoma.
No, you can, I'm just saying. So the literature is very clear, at least as far as I'm concerned. The recommendation is if you don't know what it is, then you make a judgment, shall I observe or treat right away? But if you know for whatever reason and you have some superpower to know what it is, then go ahead and treat it, and that's fine. But we also know non-growing tumors don't metastasize. And if I happen to see a tumor today and say, oh, it's a nevus, for example, by mistake, and it actually is a melanoma, and I bring them back 3 months later, I may or may not see a change still. But if I bring them back 6 months after that, which is 9 months from the beginning, what we know about the growth rate of small melanomas, you will see a change in 9 months. So you will not have waited more than 9 months to figure this out. So that's a melanoma that you mistook or misdiagnosed as a nevus is actually a melanoma in evolution, and observation delayed by 9 months in the risk of 1% metastasis over 5 years, perhaps not meaningful. This is very different than a nevus or IML transforming 5 years later into melanoma. That's a random event, can happen any time, and you can't prevent it. So you have to differentiate these two events. Early transformations are actually melanoma that you missed. And late transformations are true transformations of nevus to melanoma that you cannot do anything about.
I agree 100%. When a lesion grows over time, depending on, I'm not even as confident as you about giving it the 9-month rule. If it grows 10 years later, obviously it was a transformation that happened later. But if it grows in a shorter time period, it might have been a small melanoma or it might have transformed shortly after you saw the patient. That's why I use this tool to be able to tell you at this point, and wherever I stuck the needle, hopefully that was the most dangerous spot of the lesion. This is the finding that I found, and if it is a class 2 or a class 1 PRAME positive, in my head, or if it has a second order next gen sequencing mutation, in my head, I'm comfortable labeling that a melanoma at this point in time, and I don't have to wait a year to watch it grow. I can just treat now.
So you're saying there's nothing like class 1 melanoma? Suppose it comes back as class 1, you'd say it's not a melanoma?
So I believe in the future, our molecular testing are going to show that some lesions that we label now as melanoma because they're large have zero malignant potential.
That does not define melanoma.
Yes, it does to me.
Just remember.
Okay.
Just remember.
So we're going
to.
to.
Was classified, those were based on enucleated eyes. Hundreds of eyes were enucleated, and you do GEP, half of them were class 1 and half of them were class 2. So big tumors requiring enucleation, having neovascular glaucoma, extraocular extension, class 1. I can show you some examples.
All right, to get to our great keynote, we're going to bring this non-controversial session to a close.
It gives me great pleasure to introduce our keynote speaker. Dr. Professor Jens Kielgaard joins us from Copenhagen. He's a clinician scientist who completed his training in ophthalmology and then in vitreoretinal surgery. He's been an active member of many societies, and I think one of the real leaders in collaborative, evidence-based medicine in ocular oncology. He's a member of many elite societies in the field of retina. I've enjoyed time with him at many meetings, and including the club Jules Gonan, and also in many of the European societies that collaborate quite actively in the field of ocular oncology. I think where I'm most impressed by Jens is his commitment to coming up with the best scientific evidence to help advance our field. And in that, he's a wonderful teacher and mentor, and I've met many of his students. He's mentored over 20 PhD students who have all moved on in their careers and have been great contributors. He also gets the award for the longest distance travel to come to the meeting today. So all the way from Copenhagen, Dr. Jens Kilgaard.
So thank you, Prithvi, and thank you to the organizers for inviting me. It's really a great honor to be here at this wonderful meeting. I really like the discussions you have here. Now I hope we do it correctly. So I have only a few financial disclosures. So what I'm asked to talk about was optimizing prognostication within uveal melanoma, and then you could ask prognostication why. I've been asked that question a million times, because why do you want to do something for patients you cannot save? They do die, all the patients you try to rescue. So in Denmark we have very, very good registers. We know exactly what people die of. We know when they die. We know where they die, and we also know where they're buried. And if we can't find them, we can go out and dig them up, and we can make additional investigations. So if you follow these patients, it's actually not true that 50% die. It's actually more than 50% that dies of this disease if you just wait long enough. And here you see 50 years of follow-up, and they keep dying from this disease-specific metastases. So if you just want to know if they die or not die, we can just toss the coin, because it's basically 50% that will die, and we say that will die from liver metastases. But as we'll come back to, this is not really true. So there's been many ways to do a better prognostication for patients, and we have looked at cell types, we have looked at sizes. But the first really validated system for prognostication was a GNM classification, where Tero Kiveli from Finland played a pivotal role in defining the GNM. And there is really no N in this cancer form, because there is no lymphatic drainage from the eye. So we have the tumors and we have the metastases. And he basically built a system where he could differentiate between the different sizes and anatomical location to find what is the survival curve of these patients. But as you see, there is some of the lines crossing over. It's not so good, and the reason for that is that the numbers in certain of the groups were not very big. So he made a underestimation of the size. And also he looked at the largest basal diameter and the height, and we have some tumors which basically have a higher height than they have the basal diameter, these cuddle button tumors. And from a biological point of view, it doesn't make sense. We define the largest basal diameter as the contact to sclera, but if it's higher, then the largest basal diameter is actually the height and not the contact with sclera. So if we look at the other side, we've taken all the Danish patients and we just corrected it. But still, you see, most of the patients are actually in the T1, which is the purple, the light red color. This is the smallest tumors. And this is because many of the iris melanomas and small choroidal melanomas are actually in this area. And if you pool all these tumors together, you will have an underestimation of the actual potential for their spreading of the disease. So we thought, well, why have a two-dimensional? So basically the largest basal diameter and the height is just a surrogate for volume. So what if we try to make an artificial volume using the two structures, the height and the largest basal diameter? So I still remember we sometime talked about having a true OCT that could calculate the volume of the tumor. That would be so nice, and I think we will have much better results if we could have the correct volume. So these are all the melanomas in Denmark who has been calculated into a volume, and if you log transform them, they're actually pretty much close to a normally distributed curve. So you see you have two distributions, one small and one big. And if we go for tumors divided on the mean and the 75 and 25% distribution, we have very, very good separation of survival curves. So bigger tumors, quicker death. Then we tried so we had a problem because we could see that it was not really bimodal distributed. So we made a mathematical calculation looking for the distribution and found actually 3 distributions. And then we thought, okay, could it be that it was kind of iris melanomas, ciliary body melanoma, and choroidal melanoma? And these are printed in here, and it's not really true. So we do see that the iris melanomas are basically filling out the lower part, so we will take them out, and we'll do that for 2 reasons. One, we have no metastatic deaths from iris melanomas in Denmark, even though they grow down into the ciliary body. Unless the ciliary body part is bigger than the iris part, then it's something different. And ring melanoma is a completely different type of melanoma, and we cannot really measure the size, so we took them out also. And that leaves us with this distribution where we now looked at people who died from metastases and people who didn't die from metastases. And what you see here now is that we do have a small proportion of choroidal melanomas lying in the same area where the iris melanoma was. But we also see that all the people who died from metastatic disease have actually higher tumors than the ones with a lower, who doesn't die from metastatic disease. So if we look at the genes contribution to the people who die from metastatic disease, you see that we have only a very few normal tests that are actually what you will call class 1 tumor. We call it normal. And the abnormal is the class 1B, and the high risk is the class 2B. And basically you see the distribution of the different genetic abnormalities among the patients who died from metastatic disease. And we'll come back to the normal ones because I think these are the cases where the test didn't really work. But just to show you, this is a tumor with a volume where you have a height of approximately 3 millimeters. And from the Danish study, we must just say that if you are below 3 millimeters in height, you don't really die from the metastatic disease. So we have few cases, and we can always find the case that undermines the rule. But if you have a melanoma less than 3 millimeter, I don't think you will die from it. It will be very unlikely. So the big game changer was when we went into the genetics. So the genetics kind of is much more predictive of death than the size. But the problem with the genetic is everybody is focusing on the bad chromosomes. So in Denmark, we chose to do something different. So we looked at the good chromosomes, saying, you're never going to die from this disease, so we don't need to follow you up. So basically, we're using the resources on the people who needs follow-up, and all the ones with a normal chromosome, we say, well, you don't really need to come here because you're not going to die from this disease, so why are we going to scan you every 6 months? It's a waste of time, your time, our time, and money. But on the other hand, if you have a poor chromosome, you can see from the test that a large amount of these people actually do not die from the disease. And we haven't figured that out. Why are they not dying from the disease? But it means that there must be some kind of turnout point where you go from a high-risk patient to a mortal high-risk patient. So there must be a point of no return, and it's not just the genetic changes, it's something else. So we have seen this picture many times. It's basically showing the same thing, that you have a group of patients where it's class 1 PRAME negative that do not die. And I know that the tests are not completely true, so I think the reason why we have a 95.6% survival rate is that we miss something. We might miss the clone in the tumor that was not really normal, but for all other diseases in the body, we would accept such kind of failure and still not screen them. So I think you actually have your own proof here from your COG2 study that you have a proportion of patients that doesn't really need to be followed. But then again, there's a risk of recurrence in the eyes, and you might look at them in the eyes, but it's not really necessary to look at them in the liver. So this is when we look into just normal genetics, and then we have our class 1B is the red one, and then you have the high-risk melanomas, and they do die, but they do die over several years, and still after 13 years, there's people who is not yet having developed metastases. And if we correlate for the AJCC stage, you can see that if you have a bad chromosome, it doesn't really matter how big your tumor is. But if you have abnormal chromosomes, the tumor volume is really important. So I know genetics is very, very much more important than the size. But if you just have one chromosome missing, either 8 or if you have 3 missing or gain of 8q, then the size does really matter, because the bigger the tumor, the worse the prognosis. So these patients are the 6 patients that we missed in our analysis. And you see on the disease-free survival, it's really a big variance from very early onset to very late onset. And basically, we have one very small tumor, but the thing is, it had regrowth, and when we retested it, it actually had transformed into a high-risk tumor. So you can't say, was the first biopsy really representative of the tumor? We will never know because we didn't have the eye, but when we did the retest, we did find something else. And all the other ones are quite big tumors, and it might have been that, that we didn't get the right clone, so we put in the needle in the wrong part of the tumor, and we had tumor tissue that was not really representative of the prognostic value. And in 2 cases, we only had fish, and I cannot recommend only have fish, but today everybody is using either a system based on gene expression profiling or whole genome sequencing. This is just to show the volume. If you look at when we do our segmentation in different tumor sizes, this is all volume based, and it just shows basically the same, that if you have a normal chromosome, you don't really die even though you have a very big tumor. And if you have abnormal chromosomes, well, if you have a very small tumor, you don't die even though you have a high risk classification, but otherwise it's pretty much that it is related to the size in the abnormal group. This is just to show another way to look at it. So you can actually calculate an individual risk for your patients if you make a nomogram. We have tried to push the nomogram in many different ways, but it seems like the reviewers hate nomograms, and maybe they don't understand it, but what you can actually do is that you can make an individual prognostication for your patients, similar to the one you can do at Lumpo, and there's also other online prognosticators. It's the same thing. This is just more analog. So when do the patient die? Because that is maybe the biggest problem when we talk about prognostication and we want to say if our model is working or not. Because if we only have 5 years survival, we will find a lot of them, but this graph shows you in different HHCC sizes, when do the people die? And what you see is, even though you have a very big tumors, you can have regrowth of distant metastases at 35 years post-treatment. And that is a big problem. So this is also what Zimmerman showed, that there is an early onset where you have early growth, but then you have bumps later on the curve, also by Aaron, that you have different times where you have a higher likelihood to have metastases. So why is that? We thought this was genetics. We thought that this was probably the reason, the difference between IFAX, SF3B1 and BAP1. But I can tell you the last one, 35 years, one of the tumors we analyzed had a BAP1 mutation and loss of chromosome 3. So just telling you that didn't help us much, the genetics. So I think we must be careful to interpret what kind of genetics do we find, so we can divide them into metastatic disease or no metastatic disease. Just put this one in, and I see now I have a time problem, just to show, does it really help to treat early? So this blue line, the blue straight line, that is the background population mortality in Denmark, meaning that we all die, that is certain. And the other lines are the different sizes of tumors, showing that in the early, from 40 to 60, there was a huge over-mortality among melanoma patients in Denmark. But what you see is from 1980 and forward, the small melanomas are actually similar to the background population. So we did do something about early treatment, and we think that the reason why we have this is because in the 1980s we got the 90 diopter lens in the biochromas, and now the doctors were able to find the tumors before they actually died from them. So we do think that early follow-up and treatment makes a difference, and this is just to and it is not smaller. The average size of the T1 tumors did go down a little, but not significantly. Just remember that the melanoma patients can actually die from other diseases too. So when they do have the eye melanoma, it's not necessarily that they die from metastatic disease of melanoma. So this just shows that there's a higher risk of developing a other cancer compared to the background population. So basically 18% of my patients have other cancers they die from that is not related to the uveal melanoma in the eye. So if you just screen the liver, you might find other cancers which is not really related. So what about metastatic disease? Well, again, AJCC has some survival curves from small and medium-sized and large metastases in the liver. And this is just to show that there is a difference between them. But what we find interesting is that if you have metastases outside the liver, you can actually live for many, 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 many years. So if you are planning a prospective study, you should be able to stratify the patients according to the survival of the liver metastases. So it's not enough just to look for the largest diameter of the largest metastasis, you also need to look for location. And there has also been speculated that if you live for 10 years without your having metastatic disease, you actually have a better survival. This is not true. If you develop metastatic disease, you die in the same time range, whether you have it within the first year or the 10th year. There are many different ways to look at prognostication for liver metastases. So the AJCC is just the largest diameter of the largest metastases, whereas the Helsinki also have some liver enzymes in it. But the Mariani and Valpioni has many different, and they have a nomogram, and you can actually see that they are more specific in the survival rate. So this is just to show you that at 6 months, there's basically no difference between the different survival algorithm, the AJCC being just the largest basal diameter of the largest metastasis, whereas 24, all the other like ECOG and stuff is also dependent. I'll hurry through this. We thought, what about tumor volume burden? So this is measured by a PET-CT scan where we actually looked for what is the tumor burden of each patient and can it be correlated to survival, and it can. So it's not the activity of the tumor, it is basically the volume of the active tumor size. But what's interesting is that there's no really difference between the total volume of the body and the volume of the liver. So it has the same predictive value that it is. You can just look at the liver and you will have the same outcome as if you look at the whole body. So it seems like it's the liver we need to concentrate on. We need to treat the liver. And this is just a predictive value showing that the largest basal diameter of the largest, the largest diameter of the largest metastasis is actually the same as the total activity score from the whole body. So there's no difference. You can just look at the largest basal diameter. It doesn't have to be complicated. So we can predict survival in UM, and we can predict the survival in metastatic uveal melanoma. And it seems that the liver involvement is the most essential part of this. So we need to focus on the liver. But we need a model to predict time to metastasis, because that would be really beneficial for the patients, so we know when to use our resources. Thank you. Sorry.
Yeah. I was wondering if you could comment on you and your group's thoughts about what explains when you have a small tumor with bad genetics, why they do better in terms of survival compared to those with larger tumors and bad genetics. I have my optimistic viewpoint as to why, but I was wondering what your thoughts are.
So when I started this, I couldn't believe that metastasis in the liver was the same disease as the primary uveal melanoma. So we looked up and paired eyes that were nucleated with liver metastasis and looked for the genetics. And when you look at the variant allele frequency, it becomes very technical now. Then you can see if you have it in all your cells in the eye and all the cells in the liver, this must have been a mutation that took place very early on. Whereas if you only have it in 10%, this must be a mutation that takes place very late in the disease progression. So we can draw these phylogenetic trees where you have a stem cell and then it divides into the liver metastasis and into the eye. So right now there is a paradigm that we say we have the nevus that goes into the melanoma, then it goes into a treatable melanoma, and then it goes into metastasis. This has been the paradigm all day, saying that we need to treat the primary melanoma because then we can prevent metastasis from the patient. But that's not true. So in many of these cases, the metastatic event took place even before we realized there was a melanoma in the eye. So it doesn't really matter what you do to your primary tumor. So if the metastatic event has taken place, you cannot change that. But when does the metastatic event take place? Well, it needs some kind of volume before that happens. And that is why I'm a bit skeptical about the liquid biopsies showing that they have circulating tumor cells, because if you have a very small melanoma, and you have a lot of tumor cells in the bloodstream, it doesn't really make sense but that might be my paradigm. You need to show me that I'm wrong. So there was a very interesting paper by Gustav Stålhammar from Stockholm, where they looked at autopsies from patients with metastatic disease and some without metastatic disease. And what they found was they found tumor cells in all organs, all over the body, in both groups. So what I wanted him to do was to calculate the total volume of the cells, but it might be that there's much more tumor cells outside of the eye than inside of the eye. So when does this take place? This is the point of no return, and just from a statistical point of view, it seems that you have to have a height more than 3 millimeters. So the genetics might change very early on in order for it to grow, but the order for to have the metastatic event must be a bigger tumor. But we don't understand why you have tumor cells in the body. So Nils Eide from Norway, he took bone marrow biopsies and found that there was tumor cells in 70% of all his patients. But the strange thing was, this was bone marrow, that they did survive better than the ones that didn't have bone marrow tumor cells. And this is also a bit strange.
Quick question.
Almost 20 years ago, I wrote a paper on tumor doubling times. And there we showed that the metastasis happens when the tumor is not more than about 7 millimeter in base. Basically just detectable. That's when the metastasis is happening. And that was published in Ophthalmology with an editorial that came with it. But that's all what you said is correct. I think it's a very early event. And the meat in all of this is going after adjuvant therapy, not so much of early intervention for the smallest tumor. That's my take on it.
Yeah, so I do agree that we need new adjuvant therapy, but if we can treat the tumor without the need for new adjuvant, I think that must be better. Adjuvant, yeah. Yeah.
We appreciate your ongoing career of educating us and using data to answer questions, and thank you for making the trip.
Thank you.
Good afternoon, everybody. It's a humbling experience learning from ophthalmology colleagues. I thought medical oncology makes such a great improvement in cancer, but when I listen to your presentation research, it really humbles me. So there's a lot of things we each have to learn and improve. So this section will be managing the systemic therapy or the advanced melanoma, uveal melanoma. My talk is current status of the standard therapy for metastatic uveal melanoma. So my disclosures. So as we discussed so far, about 50% of the uveal melanoma patients will develop metastasis, and more than half the patients may die of this disease. Frequently, 2 to 5 years is the danger time we detect metastatic disease. But as we talked, beyond 5 years, beyond 10 years, it's not rare. It can happen. And at the time of metastasis, it doesn't really happen with the initial presentation, but over time, liver becomes the main predominant area of the involvement. And almost 90% of the time, the liver becomes main problems in these patients with uveal metastatic melanoma. So historically, survival duration is about 10 to 12 months in the old literatures. And we know that systemic therapy is not that great in general, and even checkpoint immune therapy is not as good as we think it was. It can go to the lung, liver, skin, soft tissue, bone metastasis can happen. And patients with high risk, we do ultrasound, MRI scan, CT scan. There's different opinions about which the modality should be the ones we screen, but still, we need to screen those patients, especially for the liver. And uveal melanoma typically has low tumor mutation burden. That's the reason why we think the immune therapy doesn't work that great for uveal melanoma. So our goal is trying to improve prolonged survival as much as we can while we keep the quality of life, a decent quality of life. So this is the International Rare Cancer Initiative, the meta-analysis of 29 prospective uveal melanoma trials in the past. When these studies, meta-analysis was done, median progression-free survival was 3.3 months, which means by the time you get the first scans after starting treatment, more than half of the patient tumors progressing already. Median overall survival is 10.2 months, less than 1 year. And most of these patients receive chemotherapy of some kind. So what we do nowadays, we talk about liver-directed therapy, since the liver is the main problems. Also, we can talk about systemic therapy, and subsequent sessions can be deal with liver-directed therapies. But today, for me, I'll just concentrate on the systemic therapies. So let's talk about checkpoint immune therapy. PD-1 treatment has such a great impact on cutaneous melanoma, but unfortunately, for metastatic uveal melanoma, quite poor the result. So this is meta-analysis of the retrospective studies. They show that the response rate of single-agent PD-1 treatment or PD-L1 treatment is only about 3.6%, and the median overall survival 7.7 months. So nothing great. And when you combine PD-1 plus CTLA-4 antibodies, so now 2 receptor inhibitors to stimulate T cells, in cutaneous melanoma, we're expecting 50-60% response rate, and nearly half of the patients live 5 years or beyond, even with advanced cutaneous melanoma. But in this, the studies, one in Europe, one in the MD Anderson, so the response rate is between 12 to 18%, not as great as skin melanoma. Complete response is rather rare, and overall survival between 12 to 19 months. So maybe it may make a little difference, but it's not really clear since it was single agent, single arm studies. So in my view, if chemotherapy was a foul ball, maybe the PD-1 plus CTLA-4 antibodies such as nivolumab, ipilimumab combination can be maybe a first base maybe, but nothing close to home run. Then we talked about target therapy. Forget the immune therapy, let's talk about molecular target. We know that 80%, even more than 80% of the chance, patient will have GNAQ or GNA11 mutations with the uveal melanoma. And we know that G proteins mutations can activate the MEP kinase pathways. And then the simple target, let's use the MEK inhibitor to block this pathway of MEP kinase pathways. Maybe it can slow down the tumor growth, it can shrink tumors. So there's 2 drugs actually tested. One is selumetinib, one is trametinib treatment. First, selumetinib treatment is the selective MEK inhibitor, And in this studies was a randomized phase 2 studies. So single agent MEK inhibitor selumetinib had 14% response rate with a median PFS of 16 weeks. So about 4 months of tumor control compared to chemotherapy, which had a 0% response rate, only 7 weeks of the progression-free survival time. But still, overall survival of the MEK inhibitor is only about 10.8 months in this study, and there's no overall survival benefit. And next, why not combine MEK inhibitor plus chemotherapy? So when you add the selumetinib plus chemotherapy compared to chemo alone, there's no difference in progression-free survival, which means if MEK inhibitor was effective, which is some improvement by itself or even combinations, but in general, MEK inhibitor itself, not a great success. So to me, it's maybe another first base, but nothing significant more than first base. Next one, trametinib, is MEK inhibitor treatment was tried in combinations with AKT inhibitor or by itself, MEK inhibitor itself, trametinib. Response rate, 5.6%, and PFS, about 4 months or less. So once again, the MEK inhibitor itself is not a great improvement in management of metastatic uveal melanoma. Then, here comes a breakthrough in my view. So this is the TEPN2, by now everybody knows about TEPN2 treatment. This is the bispecific antibody treatment. Basically, the concept is trying to get one arm of the antibody to the T cells, CD3 protein of T cells, and the other arms binding into the GP100 of the present in the tumor in patients with HLA-A201 present patients. So having these two bring the tumor cells with the T cells together, does it make improvement clinical benefit or not? So phase 3 clinical trial is a large study. The patient has to have HLA-A201 presentation and no systemic previous treatment, so first line treatment. 2-to-1 randomization to receive TEPN2 treatment versus the other groups get investigator's choice of single agent, either pembrolizumab, ipilimumab, or chemotherapy. Overall survival is the primary endpoint. And this is the main curve, overall survival. So the hazard ratio, 0.68, which tells me that there's 32% decrease in the risk of death at the time of presentation. And median overall survival time was 21.6 months for the TEBE arms versus 17 months of the chemotherapy. And this was the first time ever having any overall survival benefit of any treatment in uveal melanoma so far. And progression-free survival, how long can we control the disease, was TEPN2 was 3.4 months versus chemotherapy, the control group was 2.9 months. Hazard ratio 0.76, which tells me there is 24% decrease in risk of progression at the time of analysis. So once again, this is the first treatment. Actually, in fact, any solid tumor, this was the T-cell receptor therapeutics demonstrating survival benefit, especially in melanoma, uveal melanoma. The most recent 3-year follow-up also shows the benefit of survival with these medications continued up to 3 years. So initial concern is that maybe first year or two, patient live longer, but then everybody dies by year number 3. Then you'll be a big disappointment. But fortunately, 3 years out, still the survival benefit is ongoing. And if you look at overall response rate, how well can shrink tumors, in fact, number is quite low, 9% response rate. So only 9% of the patients have significant tumor shrinkage, but yet patients live longer term. So maybe it can slow down the tumor growth without having significant tumor destructions. So this is a kind of overview that the metastatic uveal melanoma still remains very difficult to cure, very difficult disease to cure. In general, chemotherapy is not very useful. Immunotherapy, not as good as in other cancers. So we recommend enrolling into clinical trials in patients with metastatic uveal melanoma. And so probably the first recommendation when patient comes in will be the first clinical trial is the recommended. If patient has HLA-A201 type, then we can use the bispecific TEV treatment. If they don't have HLA-A*02, then still we consider nivo-ipi as one of the treatment of preference. And what we need to do in the future is develop more effective molecular target therapies. Maybe different combinations may be important. And we need some improvement in immune therapy as well. So can we combine some liver-directed therapy with immune therapy? Also, we have to get some prediction markers, predictive biomarkers to see which patient may need immune therapy, which patient may need some type of different target therapy can be very important. So our next speakers can tell you about more liver-directed therapy and clinical trials. Thank you.
All right. Thank you to Dr. Kim. And next up will be Dr. Sunil Reddy talking about liver-directed therapy for metastatic uveal melanoma.
Okay, conflicts of interest. I do work with some of the companies here, some of which I'm getting money from, Delcath, Trisalis. I do a board for IDEA, and have had a lot of discussions with Replimune recently. But I think this all comes down to part of what I'm going to talk about. I think there's been a lot of discussion today about bias in trials, and I think intellectual bias is probably the biggest issue. Finance is part of it, but if you have a belief, it's hard to get around that belief. So outline, liver metastasis with limited systemic disease is really the target, usually of, at least intuitively, of liver-directed therapy. So I'll talk a little bit about evidence-based medicine, liver-directed therapy with an emphasis on Delcath, because Delcath is approved, so you should at least know of it. This is a diagram about screening. I just wanted to mention lead time bias. At the top, you've got 5-year survival of 0%, cancer diagnosed based on symptoms. When you start cancer screening, you have an appearance of increased survival, but it's really a lead time. This is an important concept because lead time affects everything. It's a general idea, but cancer screening is a big area, obviously, within solid tumor oncology, which is what I do as a medical oncologist. But lead time, whenever you improve technology, you have to look for lead time. It's hard to quantify, but it exists, and the question is your overall survival, how much of it is explained by lead time? So I'll talk about a few concepts in one slide. I want to cover at the top stage migration, crossover blinding. Crossover and blinding apply to randomized trials. So in thinking about those come into play, especially oncology trials dealing with metastatic disease. Then in the second set of line, the patients that are chosen are very important. Patients are obviously healthier to get onto trial, and you have to learn or think about at least how you're going to apply that to other patients. And everybody has a different approach to doing that to the sicker patients. And then the control arms are critical. That has to be improved, at least in the setting of uveal melanoma. Endpoint, very critical, but again, there's no one-size-fits-all here. So getting into this question here, 1, 2, 3, 4, 5, 6, progression-free survival is commonly used. Sometimes as a registration endpoint, measures progression and death. Relapse-free survival is usually after adjuvant. Distant met-free survival is another surrogate. What are all these surrogates for? Living longer, overall survival. And melanoma-specific survival is a variant, but it deals with, you're adjudicating that the death was due to melanoma. Whenever you have to make a judgment, there's potential for bias. And then, of course, response rate, which you usually get right away. With that in mind, we'll get to liver-directed therapy. I forgot who gave me this picture, but it wasn't from Stanford, so I apologize. I think it was one of my colleagues at ASCO. But there's a lot of treatments for liver-directed therapy, and everyone's going to go with the expertise that they have. Some of the recent trials, surgical resection is always, I see patients that have had resection of limited disease here and there. TACE, that was in the control arm of some of our trials, hepatic artery infusion, RFA, cryotherapy, yttrium beads. There's a lot of use of this, and we can maybe ask Kevin on some of their trials, combining with systemic therapy. You can radiate, now we have radiosurgery. And of course, just plain old systemic therapy. If it's that good, you just use that to treat and get away. And then isolated hepatic perfusion and variations, photomustine in Europe. And then I'll talk further about the items in red, percutaneous hepatic perfusion. That's basically Hepzato or Delcath. Trisalus, I'll just mention, SD101 is a toll receptor agonist, which you've heard about the mechanism that was used by injection. I'll mention Galvanex and histotripsy because my patients educate me about this. They see this online and ask me about it, and they know the sites that have them, so it's something that's worth discussing. This article from Tübingen, Germany, Wayans, where they looked at their data across a couple of decade points. The blue is liver metastasis in two different eras. They show a difference in survival here, melanoma-specific survival, and then they divide the latter cohort here into the more current cohort into liver-specific therapy versus systemic therapy. Their conclusion is that liver-specific therapy is important in improving survival. And of course, that's going to depend on the type of patient you encounter, whether they have systemic therapy or not, and your relative expertise at liver-directed therapy. So this brings us to Delcath, the FOCUS trial, Hepzato. These trials were, this trial was single arm in the beginning, and then there was a randomized portion. What happened to the randomized portion is, as it was slow for accrual, the FDA said you do X number of randomized patients, and then the rest of it, the trial can be filled out with a single arm. So 93 patients were randomized, and the control arm here is just like with the TEBI trial, tebentafusp, is a little bit problematic. Single agent checkpoint inhibitor is less effective than double, or at least that's what we think, and chemoembolization rather than diffuse liver therapy, which some people believe is better. Why is it a problem? It's a problem because different people treat differently, and we don't know the outcomes, and you can't conclude that this was by itself the best control arm. I'm talking about both trials. Now, just briefly to review liver anatomy, this is the liver, and they're essentially isolating the portal venous circulation. You come in through the hepatic artery, and you infuse the drug, and then you close off the vena cava. And they do this with balloons, and this is very clever. You double balloon the venous cava, so you control the outflow. You have a fenestrated catheter. You can see the fenestrations. And then you come in through the artery, and you infuse melphalan, in this case, in highly myelosuppressive doses. And then it's filtered and put back in. So you're talking multiple central lines. So you have an overnight stay, and it's done every 6 to 8 weeks. Now, this allows you to give melphalan to the liver, but you still get some systemic leak. They went through some 15 to 20 years of development. They had an original trial, but with the current filter, you are able to get people out in an overnight stay, but you do get cytopenias. So I think of this as moderate chemotherapy, okay? Not single agent chemo, which is pretty simple, but as moderate chemo. Nevertheless, you can get it done with the proper training, and no question this is clever use of interventional radiology, or as our colleague Dr. Zager, he's a surgeon, he does this. So these are their curves. They got approved on the response rate. That was their primary endpoint. Again, it's a surrogate endpoint, but 36% with liver disease is pretty good. What do you need to know here? Again, limited liver disease, up to 50%, and just limited systemic disease or no systemic disease. And if you look at the top corner, left corner, you see CRs in blue. And as with every treatment, if you get a complete response, you probably do better. So it certainly does seem to buy you some time, but the bulk of the patients were treated in single-arm fashion. So those are the numbers for better or for worse. I think the question is really, how do you fit this into everything that you do. It's much easier to give systemic therapy in the sense that our partners around in the community can give Ipi-Nivo, but they can't give this, and so on. So these are kind of the things we have to wrestle with uveal, but with all of oncology, we have a lot of different approvals, and we don't know how to sequence them. So this is the TriNav device, TriSalus. I just want to make one point. That's the device. The device is approved. Some of your radiologists are using this for different processes, but it's to help infuse something under high pressure, and that's the liver. That's the theory. Unfortunately, this slide is from Sapna Patel. They do have updated data, but I can't present that right now. But suffices to say they're not developing it any further, if that gives you a clue. So Galvanex, this was very interesting. I got interested in it because it's the lymphoid structures. Specifically, their tertiary lymphoid structures are noted. Galvanex's pulse field electrophoresis. It's like any targeted liver therapy. It's not treating the whole liver, so bear that in mind. So it turns out in doing biopsies at those sites, they showed some data for lymphoid structures forming. I don't know enough about sort of lymphoid structures forming in response to trauma, such as pulse electrical fields, but this is kind of fascinating. It works very well for spot treating lesions in the lung and liver, and it is done. The question is going to emerge. You saw that long list. How do you use these things and when do you use them? That's not determined. Or do you use them at all? Oh, let me go back. I forgot to mention the second part, the histotripsy. This is out of the University of Michigan, and they, again, have good local results. What's interesting about, or maybe not interesting to the makers, the patients, I've sent a couple now, they do it in Costa Mesa, Southern California, and you kind of take a beating from it, which is a little surprising. And so that was, it took some time to recover, not a lot of time. So to summarize, really, I think the approved treatment here, the new approved treatment is the Delcath Systems Hepzato, and it's very feasible to do when you have the setup, and I'm sure they'll be looking for sites. It uses melphalan, an old drug, but it is approved. It's better than single agent checkpoint or TACE, which is not diffuse liver therapy, and limited systemic disease, liver limited to 50% plus or minus. The TriSalus TriNav system, we do have a few patients that are doing well on the trial. I don't know where it will go. I'm seeing somebody who's been stable since the trial, which is quite an achievement since it's been a year with liver mets. So SD101 toll receptor agonist definitely has some benefit. I didn't talk about Y90, but Y90 and tebentafusp combinations with immunotherapy are probably going to be published soon with detail, and the same could be said about combos with Delcath. And then local therapy with Galvanex and histotripsy, well, they're already available. What are we doing? We're not curing people, and it's not clear what these overall survival advantages mean. Would they really show up on a curve versus a sort of earlier diagnosis? It's hard to know because, well, I'll stop there.
Thank you. Our next talk is Pauline Fonchaine, who will be discussing neoadjuvant therapy for uveal melanoma.
Good afternoon, everyone. Thank you for the invitation. I missed this last year, and I've learned my lesson. I'm clearing my calendar next year. So we're going to talk about neoadjuvant therapy in uveal melanoma. This is going to be a little bit of a romp, so get your last drink in, get your yawns out, and then we'll get going. All right, so we're going to go through many of you know this concept, but sometimes it's easier to visualize what we're trying to do with therapy, right? There are different ways we can think about how to cure these patients, right? So we know that there's melanoma in the eye. That's where we're starting. We do locally definitive treatment, which is most of you in the room, and we're very thankful for you because you do most of the curing. So actually, you do all the curing. We're still working on it on the oncology side. So if there is only melanoma in the eye, then local therapy is all you need, right? Now, as we just talked about, and thank you for setting this all up, Melanoma, any kind of melanoma, we know is micrometastatic very early, right? And so what we're seeing about 2 years later is probably something that existed at the time of diagnosis. So the idea is, how do you then treat micrometastatic disease that you can't see, right? So if you do local therapy, you don't address micrometastatic disease. So we talked about adjuvant therapy. So adjuvant therapy doesn't currently exist for uveal melanoma, although some interesting data. But the idea is you do local therapy first, then you do adjuvant or systemic therapy later. There are pros and cons we'll get to. Let's work. There we go. Then there's the idea of neoadjuvant therapy. And in a couple of slides, we're going to talk about why neoadjuvant therapy has gained steam in cutaneous melanoma, and let's see how it looks in uveal melanoma. But the idea with neoadjuvant therapy is you are starting with the systemic therapy. You address both the local disease and the systemic disease, and then you end up with, hopefully, no more micrometastatic disease, and then the local therapy cures, right? So it's working together, which we do pretty well, right? So glad to all be here in one room together talking about this. And we can see in other cancers, so this is for pancreatic cancer, another very tough to treat cancer, not curable mostly in the stage 4 setting. You can see a huge difference between surgery alone and neoadjuvant therapy prior to surgery. So what are the pros and cons? So the pros and cons, so we're talking specifically about neoadjuvant therapy. So the cons are, as you're doing the systemic therapy, there's this prolonged time where a tumor can grow, but particularly if for that particular patient, the therapy you have chosen, that tumor is not sensitive to, right? So during that time, the local disease can grow. That can complicate the local either surgery or radiation, or regional disease can grow. Maybe you shrink the primary, but you might not, for some reason, be able to reach the metastases, and those now have time to grow. You can also incite adverse events. So there can be things that put patients, hospitalize them, or put them on new therapy, and then delay surgery or the procedure that you want to use to cure. And then the treatment itself may have an effect on local therapy. So if it's something that either is radiosensitive or radio-resistant and sort of primes the tumor one way or another, you can actually affect the primary treatment. So those are the cons. Well, what are the pros? So we kind of talked about the pros. You can shrink tumor. Shrinking tumor locally is great, right? Because that is less of a local, this is oncologic bias, but the ultimate pro is that you eliminate micrometastases. And you start where the tumor burden is low outside the eye in this case, and you now cure more people. Right, so we've learned a little bit about this from cutaneous melanoma. So this is a trial that looked at neoadjuvant versus adjuvant single agent PD-1 in melanoma. And you can see the upper arm is your traditional adjuvant, so you do surgery, then you do 18 cycles of pembro, and the randomized arm was neoadjuvant, which is still 18 cycles, but 3 cycles before surgeries and 15 cycles after. And when you look at the difference in event-free survival, so this is still pretty early, we don't have overall survival yet, but in event-free survival, you can see an improvement in event-free survival in the blue, which is the neoadjuvant group over adjuvant. So just moving 3 cycles before surgery makes a huge difference in terms of event-free survival. So we have a second trial now that shows something similar. In this case, the neoadjuvant agent is a combination immunotherapy versus adjuvant, and this is a little different. So the bottom arm is the traditional arm, surgery, then single agent PD-1. The top arm is a combination ipilimumab, nivolumab, slightly different dose than what we use in stage 4. And the interesting thing about the design of the trial is that not only are you doing the neoadjuvant treatment, but you're deciding what to do afterwards based on that early assessment. So you do the surgery, and if there's a major pathologic response, no more treatment, done. If there isn't a major pathologic response, so there's a partial response or no response, then you continue with adjuvant therapy. And so what we see is, again, the neoadjuvant arm does better. What's really interesting about this neoadjuvant arm is it does better, but it also includes people who just got 2 treatments, then surgery, then nothing else, and are still doing better, right? So these are 2 trials now in melanoma, in cutaneous melanoma with immunotherapy that suggests that neoadjuvant does better than adjuvant. So what about uveal melanoma? So there was some very interesting data now about 2 years ago looking at a combination therapy, IDE196 and crizotinib. And this was testing in metastatic uveal melanoma patients, but there were 5 patients where there was a proof of concept use neoadjuvantly. So these patients, in 5 out of 5 lesions, there were reductions in size, so reductions of the local disease, some very significant reductions of 74%, 67%, so big reductions. And all of them had, so important for our patients, improved visual symptoms. So this was a really promising signal. And in fact, one of the patients got splashed all over Australian news. And this particular patient, Mr. Carroll, had so much reduction, so he had a 24% reduction, that he was planned for enucleation and did not receive enucleation and was able to get brachy, right? So this is huge, something that we can never see happen in the natural history of uveal melanoma. So this was very exciting. And what is this drug? So IDE186, it's a PKC inhibitor. So you have all seen and are very familiar with the GNAQ11 mutation that upregulates the RAS-RAF-MEK pathway. This then upregulates tumor proliferation. So IDE186, or darovasertib, which I still am trying to pronounce fluently, so daro, inhibits PKC, and that then inhibits the growth pathway of RAS-RAF and MEK. So a trial, which is open at many of your sites and here as well, is looking at single agent IDE196 neoadjuvantly for up to 6 months, followed by definitive local therapy with the option to do adjuvant therapy afterwards. We don't have data from this yet, but we do have data from a phase 2 study that looked at a very similar design that was presented at ASCO earlier this year. And this was 1 month of IDE186, enucleation and an optional adjuvant, or same process with brachy. And you can see, so this is a spider plot on the left. Every time you see something go down, that is essentially tumor reduction. A different way to look at it is the graph on the right, and you can see that bars that go down are a reduction in size, and most of the tumor shrank. So a patient that allowed us to share her images on study. So she's 74. She had pretty severe vision loss to 2500. And these are Prithvi's beautiful pictures that he shared, thank you. You can see this is her at baseline on cycle 1 and cycle 5, so pretty significant reduction. Very promising. And her vision is just, she could potentially get a driver's license again, right? But there are so many more questions now. She was someone who was slotted for brachy or for enucleation. Can she safely go to brachy? What do you treat her with? For all these patients who have reductions, do you treat them for the original size, for the size after therapy? Do we need adjuvant therapy? And what are these long-term outcomes? Oops. This is the team. Our growing melanoma team that is doing all of this awesome work and putting this trial, which is a lot of organization, together. So in summary, neoadjuvant has a potential benefit for less extensive local therapy, for reduction of micrometastases. This may increase our margin for cure. It is certainly looking very promising in cutaneous melanoma, and we are basically switching to neoadjuvant when we can at this point. And uveal melanoma has some promise in this arena. We'll see how it goes.
Next up, our co-moderator, Allison Bitoff-Warner, will be presenting current states of clinical investigation.
All right. So thanks to my colleagues, Dr. Funchain and Dr. Kim. They made my job beautifully easy by setting all of this up. So I'm going to be talking about clinical trials. And for the first time, I think probably in the history of uveal melanoma, 10 minutes isn't enough to cover all of the ongoing clinical trials, which is probably the coolest thing I can say as a medical oncologist in this field. So yes, so I'm going to focus on 2 of the actively accruing trials. We saw some preliminary data from ones that have recently finished accrual from some of my colleagues. These are my disclosures. Probably the most relevant to this talk is I do serve on the steering committee for the Replimune RP2 trial that I'm going to discuss today. And we are an open site for that trial. So metastatic uveal melanoma, you just heard Darrow-Kriz. You heard at least the Darrow data presented by Dr. Funchain. And in the metastatic setting, that is now being combined with the c-Met inhibitor crizotinib. And so key eligibility data, or key eligibility criteria for that trial are the diagnosis of metastatic uveal melanoma, measurable disease by RECIST 1.1. So for those of you who live in the ophtho world, that's essentially having a centimeter of tumor outside of the eye, somewhere that is actually measurable. And bone does not count for that, but for our purposes, liver is the most common site for uveal melanoma. A performance status of 0 to 1, and adequate organ function, which essentially means normal liver and kidney function, with some modifications for patients who do have liver metastasis, although AST, ALT still need to be less than 2 times the upper limit of normal for this trial. So the treatment is a combination of Darrow plus crizotinib, at the same Darrow dosing that we see and was already presented by Dr. Funchain, and the addition of crizotinib 200 milligrams twice a day. Patients are treated until progression or unacceptable toxicity and get scans plus circulating tumor DNA every 8 weeks and multiple interim analyses. So there was actually an initial presentation of these data at the European Society for Medical Oncology just a few weeks ago that I was at in Barcelona, presented by Meredith McKeon. And the first 63 patients were actually presented, including 20 patients treated in the front line. This included a really high-risk patient population, so 60% more had greater than 2 times or greater than the upper limit of normal for LDH, which we know is a prognostic marker in melanoma. 56% had 3 to 8 centimeters of tumor as the largest tumor size in the liver. An 8-centimeter tumor in the liver is a large, very difficult to treat tumor, and one that actually may not be eligible for liver-directed therapy due to some limitations there. And 10% of the patients had greater than 8-centimeter tumors in the liver. And so this is any line data that you can see presented here, 63 patients, and exactly as Dr. Funchain said, essentially we want to see these lines going down. We have a long line, darker line at 30%, which is where we can actually technically call it a partial response on treatment or on trial. 92% of the patients treated on this trial had some degree of tumor shrinkage. 43% met that 30% shrinkage criteria to be called a partial response. 62% of the pretreated patients had 2 or more prior lines of therapy, so heavily pretreated patients in the metastatic setting, and that went up to a patient who had 6 prior lines of therapy. You can see 30% of the patients had a confirmed objective response. No complete responses, but confirmed partial responses, as well as 59% of patients who had stable disease. And just as we saw from the TEBI data, right, stable disease is a gigantic win, right? Stable disease translated to overall survival benefit in tebentafusp, right? So while all of us would love to see tumor shrinking, and trust me, we do, stable disease for patients with metastatic cancer, and particularly in the refractory setting, is actually a huge win. So we add stable disease and partial responders together to get what we call DCR, disease control rate. And in these initial patients presented, that DCR was 89% of patients. Exceptionally promising for this combination. You can see these are a different way to look at the data swimmer's plot that essentially shows the durability of these treatment responses. And so the longer the line, the longer the response is ongoing, and the longer patients are surviving. But interim analysis here with the median progression-free survival of patients treated in the first line of 7.1 months, any line of 6.8 months, and patients who had liver-only disease, which is many of our patients with uveal melanoma, had a median progression-free survival of 11 months. Data that I don't have time to show you shows that this was independent of HLA status, which is critical since so many of our patients will not be eligible for tebentafusp or will ultimately progress following treatment with Tebi. And so, again, really promising data here from this Darrow-Criz trial. And this trial is open and accruing, and I will give a shout out to Dr. Kim for having this one open. And so, really looking to increase accrual in this trial, get this done, get this completed, and potentially get this to our patients as soon as possible. The second trial that I will focus on is this Replimune RP2 plus nivolumab. And this is a different approach. So this injects a tumor with an oncolytic virus. And this virus, in this particular case, is a derivative of a herpes simplex virus. It is inactivated and then modified to do a few different things. So there's an initial RP1 variant here that adds a fusogenic glycoprotein that is more immune stimulating than just using the herpes virus alone. And then the newest RP2 here adds a CTLA4 domain, which is thought to increase this systemic immune activity and potentially allow for more efficacy of uninjected lesions. So we know that many of our patients have multiple sites of disease. We may not be able to inject all of them, particularly when we think about doing repeated liver injections. And so this addition of this domain is really critical if, in fact, it allows for what we call more of an abscopal effect or treatment in uninjected lesions. So essentially, you have a diagram here on the right, which is we inject a tumor. That might be a tumor in the liver, or that could be a peripheral lesion, something like a lymph node, or even a cutaneous met for patients who do have them. And we do hopefully see responses in uninjected lesions. And I'm going to show you some data on that. So these data were presented as part of a much larger presentation at ASCO this year, but these were the uveal patients. So in uveal patients, very small number of patients, 17 patients, 3 of whom were treated with just the injectable, 14 of whom will receive both the RP2 plus nivolumab. But you can see no complete responders, but a total of 5 partial responders, 1 to just the injected, 1 to just the injectable. And I will note that all of these patients were required to have a lesion that was injected and one that was not injected. And that is actually required to go on this trial. And so this patient with a partial responder actually had a response in the uninjected lesion, even without nivolumab. So the objective response rate in this group was 29.4%. But again, that disease control rate, when we add in stable disease, of 58.8%, another huge win. And again, showing that this is independent of HLA status for this trial as well. The majority of the patients on this trial actually had received both CTLA4 and PD-1 in combination, 70% of those patients. So these are refractory patients who were still responding to an immunotherapy-based approach with the addition of RP2. So this trial is brand new and open. It literally opened to accrual here at our institution yesterday afternoon at about 5 p.m. This is a phase 2, phase 3 trial of RP2 plus nivolumab in the front line for ICI-naive patients with metastatic uveal melanoma. They do need to be candidates for an immune checkpoint inhibitor because they will receive nivolumab. There's a 1-to-1 randomization. This is a randomized trial. As Dr. Reddy pointed out before, we do not think that single agent checkpoint is an appropriate comparator, so that's not what we did on this trial. These patients are randomized 1-to-1 to RP2 plus nivolumab versus ipilimumab plus nivolumab, the best standard of care that we know. For patients who are HLA-A2 positive, they are allowed to have received prior to bempifusp. So that is critical. Any eligible patient can have had prior to bempifusp. This is just a bit of the dosing strategy, and I won't go into a lot of details here, but essentially this injection is done every 2 weeks. And while that sounds like a lot, it is important to remember that tebentafusp is given every week. And so we are working on making this more convenient for our patients. 2 weeks is better than 1, 4 weeks will be better than 2 when we can get there. This is the overall strategy. So as I mentioned, if patients are O2, O1 positive, they are eligible to have received tebentafusp prior to going on this trial, or you could opt to put them on this trial directly prior to receiving tebentafusp. If they are not O2, O1 positive, then they would go directly to this trial as a frontline treatment strategy. It is really critical to note, and as Dr. Reddy pointed out, we have no idea how to sequence treatments for our patients in medical oncology. No prior liver-directed therapy is allowed on this trial for a variety of reasons, one of which included safety, given that we will be injecting a virus into the liver. With that, I will say thank you to our team that Pauline highlighted, and I will hand it off. All right, our next speaker is Colleen Sabula.
Yep. Thank you so much. I'd like to thank the organizers for allowing me to come today to this wonderful meeting. I'm going to talk a little bit about BAP1 tumor predisposition syndrome and how we're using that in precision medicine. So I'd especially like to give a shout out to Kaylee Ramsey. So she is our new physician assistant that is working with me and that we hired to help really drive this forward. And then my other colleagues, including Mohammed Abdul-Rahman, Dr. Dave Dorff, Lindsay Byrne, and Amy Eads. So of course you've heard a lot about some of the precision medicine advances in uveal melanoma, especially we're excited about all the new treatments for the disease. But our group has been really focused on this BAP1 tumor predisposition syndrome and how can we try to prevent metastasis in the first place by screening people. So BRCA1 associated protein 1 is independent of BRCA1. It's a tumor predisposition gene. And with germline alteration, these people really get tons of cancer and they have an increased risk of developing uveal melanoma that's about 1,400 times higher. And so these are the tumors that we should be watching out for in patients with this syndrome. So of course, uveal melanoma, that's the youngest presenting and most common cancer associated with the syndrome. We also have renal cell carcinoma, mesothelioma of the pleura, and especially the peritoneum, cutaneous melanoma, basal cell carcinoma, and there are associations with meningioma, especially the atypical meningiomas, hepatocellular carcinoma, cholangiocarcinoma, and sex cord stromal tumors. So who's at risk for this? So a nice publication with Chris Bowen, Dr. Singh, Mohammed on showing it's really younger patients will be presenting with uveal melanoma, as you can see in the red curve to the left. These are also patients who may have more than one ocular melanoma, multifocal, and also familial uveal melanoma. And then if you see a person with a uveal melanoma and they have renal cell carcinoma in their family or themselves or other BAP1 tumors, you really want to think about looking for BAP1 in these patients. So what if you do your biopsy on the uveal melanoma and you see they have BAP1 mutation? Does that mean they have the syndrome? So no, the risk is actually relatively low. So it's about 2.5 to 5% of somatic BAP1 mutated tumors will have BAP1 tumor predisposition syndrome. And that's because it's relatively common. About 40% of unselected uveal melanomas that we biopsy will have a BAP1 mutation, and then only 1 to 2% of all the unselected uveal melanomas have this germline BAP1 alteration. And of course, the germline is diagnosed with like a blood test or a saliva test. So uveal melanoma diagnosis and treatment, we probably want to be more aggressive with these patients in terms of treating early. So to consider treating with 2 or more high-risk criteria, or certainly with a melanoma growth rate, like Dr. Singh has published before, about a 0.5 millimeter over a 6-month period of time of growth, because they do have a higher metastatic rate. So what if you have a uveal melanoma patient that has a germline BAP1 mutation? How are you going to manage them? Well, we manage them by using a high-risk protocol for surveillance. And so this is our, on the left we have our genetic counselor, and then we have our many of our medical oncology colleagues. So many of them, what they'll do is they will follow with a high-risk protocol, screening them every 3 to 6 months, starting with every 3 months for a couple years, and then if everything is okay, stretching it out to 6 months for a total of 10 years per the NCCN guidelines. And so there are some variations on that, but that's what is generally recommended. So what about cancer prevention? Could we maybe use this to hopefully prevent cancer or improve outcomes? Well, I think we have some hope from another tumor, tumor predisposition syndrome, the VHL story. So in the 90s, the VHL, the median survival was only 49, and now in 2019, it is 66. So we've really made a lot of progress. I think a lot of the credit goes to these VHL clinical cancer centers, where they actually really, implement the screening guidelines. And so I think that's really exciting. I think what we want to use as our model for thinking about BAP1. So we've tried to create this at Ohio State. So what we've been doing is developing a multi-specialty clinic. We have defined screening protocols for early cancer detection. We provide patient support and counseling, research, and hopefully we will expand this to other genes that predispose to uveal melanoma and other cancers. So we have several provider partners from ophthalmology, as well as cancer genetics, neurosurgery, urologic oncology, mesothelioma, dermatology, cutaneous cancer oncology, and pathology. We follow the screening recommendations that are outlined in the gene reviews. So this is a nice resource. So typically we recommend ophthalmologic exams beginning at age 11, and then yearly dermatologic exams beginning at age 18, and then surveillance imaging. So what is that? So there have been NCCN recommendations for kidney cancer in terms of BAP1. So they recommend getting MRI of the abdomen every 2 years beginning at age 30. Or if a family member has had a renal cell diagnosed at a younger age, we want to get that 10 years before that age of diagnosis. In terms of looking for mesothelioma, there are no definite screening guidelines. This has been proposed by Carboni and colleagues to obtain MRI of the chest every 2 years beginning at age 30. And again, I talk a lot about MRI. We really want to avoid CAT scan or radiation in these patients because that could increase the risk of secondary cancers, theoretically. Meningioma surveillance, I wanted to mention one thing with the MRI of the chest. We do not typically get reliable insurance approval of MRIs of the chest, so I'll just mention that. But our other tests, we do get the MRIs approved for kidney cancer, and of course it'll check all sorts of other things, so that's a benefit. We also typically have pretty good insurance coverage for the craniospinal imaging, so this is to look for meningioma. So we look at the brain and the spine, and we do that every 2 years beginning at age 30. And of course we do the eye screening, so we have our eye protocol. So I'll just mention that we do like to include screening of the ciliary body in our protocol with an immersion ultrasound, because that's the main part of the eye that's hidden that could develop tumors. We look at the posterior ultrasound. We use wide field imaging, wide field photos for that. So we currently have 21 clinical germline patients that we're following, 3 patients who have passed and 3 patients with a variant of uncertain significance of BAP1. And we also are sequencing research patients as well. I see them for the initial evaluation to our clinic, and then our physician assistant, Kaylee, is going to follow them up, and she coordinates care and helps order the different testing. And we're really working on some different natural history reviews, enrolling patients in our BAP1 consortium. So we actually have a clinical trial that's an observational trial through NIH.gov. We have involved our destination medicine part of the, so we can see patients from outside of Ohio, and we want to minimize radiation. So here's some quick cases. So this is a patient that didn't have a genetic diagnosis. She was just referred for this iris lesion from an optometrist and had noticed my pain, discharge light sensitivity. So this is their iris lesion. And unfortunately, it turned out it was much more than an iris lesion. And so she had a uveal melanoma, and it was large, and we ended up enucleating the patient. The patient had a class 2 melanoma, and as you can see with the BAP1 mutation at the bottom, there was a very high allele observed variant of the allele frequency, so 93%. And that's always, you want to be a little suspicious for a germline when you see that high percentage. So this is the patient's pedigree. So she's in the middle, and actually her daughter had developed a renal cell carcinoma at a very young age, 37, and she actually had her result of BAP1 identified before for our patient, who then was also tested and was found to have germline BAP1. So as you can see, there's a lot of BAP1 cancers in this family. So we got her involved in our BAP1 clinic. We started the surveillance imaging, and then we're enrolling the other family members. Here's another case. So this is somebody who has a genetic diagnosis, 29-year-old referred to our clinic for this. No personal history of cancer. Here's the pedigree. So the patient's near the bottom. Exam was pretty good, but we see an iris nevus. So this is their nevus that we're monitoring. It looks benign at this time. But on a follow-up visit, we see a new eyelid lesion. So that turned out to be a basal cell carcinoma in this young patient. So we were able to catch that. We're continuing to monitor the iris lesion. And then here's the last case I'm going to talk about. So this is another patient with a genetic diagnosis. The patient was, the testing was performed in this patient after her daughter developed a meningioma at age 24 and had multiple basal cell carcinomas in her 20s. And in her family history, she had renal cell carcinoma and also an unknown lung cancer in her father. So eye exam was pretty okay. But on her craniospinal imaging, we did find a meningioma of her spine, and it was sent to neurosurgery. So she underwent laminectomy and biopsy and resection of the lesion. Is doing well. So we're just, again, working with our partners. We're learning a lot as we do this, and we're excited that we have some early successes with this. So if you are interested in collaborating or sending patients or learning more, please contact myself or Mohammed Abdulrahman. Thank you very much.
And for the last talk of this session, Dr. Ivana Kim will be talking about the current status of ctDNA assays for uveal melanoma.
Great, thank you. Sorry, I'm standing between you and wine, but I will try to go fast. There's been a lot of good discussion about the utility of liquid biopsy in uveal melanoma, and I think a lot of the work being done on the aqueous and vitreous in terms of proteomics is really interesting. But actually, circulating tumor DNA is probably the most well-developed liquid biopsy so far. And when we talk about ctDNA, we're referring to the small component of cell-free DNA in the blood that is presumed to be derived from circulating tumor cells or from necrotic tumor cells. And there's many different ways of identifying ctDNA, and we'll kind of get into somewhat of the differences between the different assays. So in terms of potential clinical applications in all of oncology, it's been used now for treatment selection, monitoring of treatment response, early detection of disease progression, also for prognostication and risk stratification. And actually, there's even been a study looking at it for early detection of asymptomatic primary cancers. So specific examples is pretty routine these days in terms of when non-small cell lung cancer is diagnosed, to try to do a ctDNA assay to look for the presence of EGFR mutations to determine if a patient is a candidate for those for that type of targeted therapy. And it can also be used to monitor for mutations conferring resistance to targeted therapies. And then the other major use is in detecting what we call minimal residual disease. It's shown to be predictive of relapse in multiple different solid tumors, and it can become elevated well in advance of radiologic evidence. So clearly, it's utility in uveal melanoma is enticing and being explored. Here's one more recent example of how it's utilized in adjuvant therapy, which is definitely applicable to what we've been talking about. So in patients with stage 2 colon cancer, they were randomized to get adjuvant therapy, not just based on standard clinical pathologic features, but also the presence of ctDNA. And in this trial called the Dynamic Study, showed that the 2-year recurrence-free survival was similar when ctDNA was used to make the decision as to whether a patient received adjuvant therapy or not. And the important thing about this, one of the details to understand, is that the ctDNA assay used in this study was a tumor-informed, very personalized ctDNA assay. So they got samples of the colon tumor, derived a personalized ctDNA assay, and used this tumor-informed assay for every individual patient. So going into the assay techniques, that type of personalized assay is based on next-generation sequencing. It can detect multiple novel mutations. It's not the same for every patient. However, it's a little bit more cumbersome to develop. There's longer turnaround time. You clearly need an original tumor from which to derive the assay. Others have looked at highly sensitive digital PCR methods that you can use pre-specified mutations. So basically it's tumor agnostic, which is, fairly, probably uveal melanoma is one of the best tumors to look at this type of assay in, because there's very few recurring mutations. The majority of uveal melanomas have a limited subset of mutations. So it's possible that uveal melanoma is one of the best cancers to explore a tumor agnostic assay in. So how do we use ctDNA so far in uveal melanoma? Well, for prognostication of primary disease is probably not the best. So there have been really variable rates of detection in localized ocular disease, spanning anywhere from 2 to 100%. I think the 100% is a far outlier, and probably the reality is more on the order of 30 to 40%. And our keynote speaker was involved in a recent study too. So that 30 to 40% is probably not enough to be able to provide prognostic information to every patient with primary uveal melanoma. We can try to optimize our yield on this by looking at the timing of blood draw. There's some evidence that radiation treatment does kind of induce somewhat of an increase in ctDNA, but in the Scandinavian study, they did not have increased detection rates during fractionated stereotactic radiotherapy. Jasmine Francis at Memorial did seem to show that there were higher rates of detection at about 2 to 3 days after plaque placement. And maybe by improving the sensitivity of the tests that we're using for uveal melanoma, we can possibly get those rates of ctDNA detection a little bit higher than 30 to 40%, but it's unlikely to get to 100% where we are now, or almost 100% by doing direct tumor biopsy. So we probably are not going to use ctDNA to replace direct tumor biopsy for prognostication, but it could be used in conjunction with FNAB and gene expression profiling to possibly guide the decision for adjuvant therapy, like was demonstrated in colorectal cancer. So what about looking for minimal residual disease? There have been publications showing that ctDNA elevations may precede the clinical diagnosis of metastatic disease by several months. Again, with current assays, our detection rate in patients with established, known imaging, proven metastatic disease is only 60 to 75%. So can we achieve greater sensitivity? Do we need to achieve greater sensitivity? And if we start using this, will we accept a positive ctDNA assay and just suggestive imaging? Will we require tissue-based confirmation in a high-risk patient as an indication to start treatment? I think that's something that we're going to have to decide as a community, because then what is the point of putting people through all these sensitive assays only to have them kind of live in more uncertainty until their lesion gets big enough to have a tissue diagnosis? It's pretty clearly established right now as a prognostic factor and a good biomarker in terms of response to therapy in the metastatic disease setting. In the TEBI trial, about 61% of patients had baseline detectable ctDNA. The assay used here was a custom NGS panel by Natera, which unfortunately is not commercially available. It's only available in the research setting. But you can see, in contrast to the percent of patients with, reduction in tumor volume or shrinkage of the tumor on radiographic imaging, there was a much higher proportion who had any reduction in ctDNA. And both clearance of ctDNA and also the percent reduction of ctDNA at 9 weeks correlated with overall survival here. And the experience in France really mirrors the experience in the pivotal TEBI trials. They used a ddPCR assay looking for, actually they used two assays. They used a ddPCR assay initially, and then they also did a tumor-informed assay looking at specific mutations by sequencing. But overall, 61%, the identical number, had detectable ctDNA at baseline, and it was both a prognostic factor. The presence of detectable ctDNA at baseline predicted overall survival, and clearance during the study also correlated with overall survival. So here is where we stand in terms of not yet process, but probably near future process. I think we're still going to be biopsying primary tumors. We can use GEP information and also the NGS information combined with a ctDNA assay. Are we going to get to a point where we'll have a very highly sensitive tumor-informed assay that can be derived from an FNAB from a primary tumor? We're not quite there yet, but I think that is an area that's going to be explored. And then we're on the cusp, hopefully, of an effective adjuvant therapy. So is that adjuvant therapy going to be for all class 2 patients, or is it going to be for class 2 ctDNA positive patients, or is it going to be for just any ctDNA positive patient? And then for those with negative ctDNA at baseline and high risk, or those who completed in course of adjuvant therapy, there would be serial sampling for ctDNA, and at the signs of a positive assay, then we would go on to imaging and then therapy for metastatic disease, and the response to therapy is going to be monitored by an assay as well. So I think we're not quite at this paradigm yet, but I don't think it's going to be very far before we are doing this. So thank you for your attention.
I'll start with a question that I always struggle with to the medical oncology group. First, I'd like to mention it's so exciting to have medical oncology as part of our conferences now. 10 years ago, there was no role for medical oncology in these conferences. 5 years ago, all of a sudden, these breakthroughs are happening, and we're learning so much, and our patients are benefiting. I can actually, 5 years ago was the first time I saw a signal where we're making a difference, and you guys are making a difference, and it's so exciting. When it comes to tebentafusp, I think if I understood correctly the study, some of the patients that do progress are having improved overall survival. And so the typical cutoff criteria of stopping a drug as soon as you see progression appears to be not perfect in this subgroup, especially when there's no second-line agent that's approved. I was wondering how the medical oncology group decide when to discontinue. I know what my local group does, but how the medical oncology group decides when to discontinue it when you're seeing mild progression.
Yeah, I guess maybe I'll start us off, and then this is really challenging, and to be fair, there are no real criteria for this. It's important to note that on the TEBI trial, treatment beyond progression was allowed, and that was done routinely. I had many patients on the initial TEBI trial when I was at Memorial Sloan Kettering, and we treated many beyond progression. And I think, it is exactly as you said, right? Is it a small amount of progression, or are you seeing, wildly explosive disease, a bunch of new lesions, right? So I think that's part of it. And there's a lot of this that goes into patient preference at this point, right? I mean, TEBI is a weekly treatment. It is a lot to ask of a patient to get this weekly if it's not controlling their cancer, right? And so, some of it is clearly there are times where we will say you might want to keep getting this, but it's not working for you. And thankfully now we are starting to see trials that are allowing treatment beyond TEBE progression, right? And so there are other options that are coming, and a lot of it really becomes patient preference. I'd be interested to hear what my colleagues think.
So if you look at the actual data, right, the percentage of people who have tumor response or overall response rate is 9%. So, and if you look at the absolute number, the difference between people who are, event-free or living, not living at like 2 years, it's about a 15% difference. So you know that there are definitely more people benefiting than people who are having their tumor shrink. And if you look at the mechanism of the drug, I mean, it makes sense. It recruits T cells, that makes it have space. So if you're just at a stalemate, right, it's growing because you're recruiting more immune cells, but the actual tumor isn't growing, then you feel like you can keep going. But, right, we don't have a test for that. There's no, there are people working on different types of PET scan, imaging, different ways to look at it. Every now and then we do have patients who are positive on our commercially available ctDNA tests. I definitely have had patients who have had growth in their scans, but reduction in their ctDNA, that helps. You can do it a little bit by performance status. How are they doing? Most of our patients are asymptomatic. Even with a decent amount of tumor, they're asymptomatic. So it really becomes, how much is this growing? It then becomes really a call. Is it too many? It's just so many new lesions. New lesions in particular worry us. And then explosive growth worry us. But if it's just sort of slowly growing, that's usually when we'll keep going.
That's well said. Let me add one more thing. In the clinical trials, even NIVO-EP trials, you can continue beyond progression as long as you can confirm. But then in the real practice, some patients have really slow-growing tumors. So I have patients with uveal melanoma, NIVO-EP, and slow growth, certainly this is progressions, 2 years to leading fine. In fact, she's leading 5 years in metastatic disease. So this is we see more often nowadays in immunotherapy in general, not just TB itself.
I think one of the challenges in that setting, and especially with some of these uveal patients, maybe more so than some of our cutaneous patients, is some of the natural history of this disease can be very, very slow growing. And the question is, even if you took them off and didn't put them on something else, and weren't making them come in once a week to get an infusion and take a day off of work or do whatever they're doing, they might have slow growing disease anyway. So if you know something about the natural history of this patient's disease, right, as many of our patients are getting routine MRIs, and particularly those getting EOVIST MRIs, where we're catching these so small, but we can't biopsy them yet, and we're watching them for 6 or 8 months getting more and more anxious, but there's nothing we can do about it. You may have a sense of which the rate your patient's melanoma grows anyway, and be able to compare that to the rate that they're growing on TEBE. That may change, the rate can change over time, but it can be one indicator that I've used for sure.
So earlier today there was a discussion about need for surveillance and finding the tumor to be small, and we talked about it that in TEBE trial and also in Scandam trial, smaller metastatic lesion led to better outcome. How about the IDEA trial, Dr. Peter Warner? You showed a graph from some of the poster, I guess, from a meeting. Could you elaborate on that? That were there a correlation between the metastatic tumor size versus the response?
Yeah. In all of medical oncology, the principle holds: smaller tumors will always do better. I mean, this is just universally true in medical oncology. I think one limitation that we do have, and our speaker made a beautiful comment about, like, wouldn't it be nice if we knew if ctDNA positivity was a reason we could treat patients, right? We do fundamentally, for all clinical trials, have to wait until patients have RECIST measurable disease for metastatic trials, so they have at least a centimeter of disease somewhere. And that's something that we would love to see change over time, but that is the minimum of any of these patients who went on trial. And right now, the numbers have been too low to really look at tumor burden. 17 patients in the RP2, I can't remember, it was 63, but I don't know that I've seen the analysis by tumor size yet from the prelim analysis, but absolutely when this reads out, we'll know. But smaller is always going to be better, and I think this is where, it is helpful to catch them small and perhaps increase your surveillance interval so that the second they're at 1 centimeter and would be eligible, you're not waiting until it's 2 centimeters.
The patients, the tumor dynamics that you see with treatment on that trial are pretty typical for TKIs and targeted therapy, which is it doesn't really matter how much tumor there is in terms of whether people respond or not. People just sort of, whether they have a lot of disease or a little bit of disease, they'll respond and shrink like 50%. But with TKIs and targeted therapy, the trick about tumor size is how long that response lasts and the chances of actually getting to elimination. And that's the part that really matters when it comes to that class of drugs.
And can I ask a question about that? For the TEBI trial, follow-up question, I thought the only advantage of smaller tumor burden was less risk of a cytokine storm, but was there actually also a longer effect as well? Okay, thank you.
Yeah.
Can I ask, these cases where you have very small lesion on MRI, I presume, how many of them actually progresses and are? And how many of these small lesions in the MRI liver scan is actually melanoma, and how many doesn't progress?
Yeah, it's a great question. Kevin and I were talking about, there's actually a Delphi committee that was recently assembled to talk about what the scan intervals should be based on the new, risk stratification papers that have come out in uveal. And this conversation went on for 30 minutes about, when we catch a 1 millimeter tumor on EOVIST MRI, right, how much of it pans out. So EOVIST is much more sensitive for melanoma, and so most of those will turn out to ultimately grow into metastatic disease. I don't know that anybody has published a real number here. It's a pretty high percentage. The probably bigger challenge is on a classic GAD-enhanced MRI, where you are picking up hemangiomas, cysts, and other things that will also GAD-enhance. And this is where EOVIST might actually be a little bit more helpful. Even though it catches things smaller, it's a little bit more specific. But I don't have a real number for you, and I'm not sure that a good one has been published recently.
It's probably in the low single-digit range. I mean, just looking at the biopsy data, I was a little bit shocked. I've had a couple in a row that the biopsy didn't show melanoma, and the radiologist read it out as melanoma. So I think you got to look carefully at their medical history, especially the younger patients who you assume are healthy. But low single digits is what I would guess. But yeah, it's something that needs to be studied. And then you talked about sort of things that we call melanoma, but they're not going to progress. There's sort of that issue. With the MRI, I've had somebody I've been following for a year now, and a year plus, and it's not big enough to biopsy. So that's a little bit surprising.
Yeah, Irene Noguera Troyes from Delcath. I just also want to mention the Chopin trial, that its proof of concept is intriguing data, only 7 patients, with the caveat that none of these 7 patients had extrahepatic disease. But the overall response rate is 85%, and the disease control rate is 100%. That's the data that was presented and published. I think the last patients are going to be accrual this year, and the data likely at ASCO, but it's something to keep an eye because it's important for these patients. Thank you.
Yeah. All right, I think we are probably at time.
Cutaneous T-cell lymphoma for the last 5 years. So now his cutaneous lymphoma was of the gamma delta variant, which is a rare and aggressive variant characterized by the proliferation of mature lymphocytes, and it was expressing the mycosis fungoides. I'll be talking about mycosis a little later. So So for his skin lesion, he had multiple local radiation therapies, and he was also status post total skin electron beam therapy. On ocular examination, the visual acuity in the right eye was 20/60, left eye was 20/40. Both eyes had early lens changes, and he had granulomatous anterior uveitis with keratin precipitates. The fundus examination was hazy because of dense vitreous haze, but there were no other retinal lesions. On OCT of both the eyes, there were multiple posterior vitreous cells. Right eye showed a pre-retinal deposit just at the fovea, but there were no signs of intra-subretinal fluid or intra-subretinal or sub-RPE deposits. We also got the angiography done for both eyes. The view was hazy because of the vitreous haze, but there was no signs of any active inflammation, no capillary non-perfusion areas or optic nerve head edema. So we kept a high suspicion of intraocular lymphoma, but we wanted to rule out other causes. So we got an extensive uveitis workup done, which included the ESR, CRP, RA factor, serology for syphilis and TB. We got the patient restaged with lumbar puncture, and the MRI brain was non-contributory. So the right eye, we decided to go ahead with a diagnostic pars plana vitrectomy. The left eye resolved on its own without any treatment. So the vitreous sample was sent out for cytology, which showed the lymphoid cells. The flow was paucicellular, the viral PCR was negative, and the MYD88, which is suggestive of B cells, was also not detected. So the pathology team decided to send the vitreous sample for the STAMP. Now STAMP is the Stanford-based the actionable mutation panel. This was consistent with the patient's T-cell lymphoma, and it also expressed various new mutations. This confirmed the diagnosis of intraocular T-cell lymphoma. That's very rare. The team looked into treatment options, which were systemic and local methotrexate and radiation. But as the first line treatment, the team decided to go ahead with high dose methotrexate therapy. So initially, after starting the methotrexate, there was improvement, but after 5 cycles, the patient came in with new vision loss. The vision in right eye now was counting fingers at 2 meters. On fundus examination, we noticed a white lesion in the macula, and there was corresponding intraretinal opacification, which we thought looked like PAMS. Now, PAM is the paraacute middle myelopathy, which is an OCT finding, and it is suggestive of retinal capillary ischemia or vascular occlusion. We thought that even with chemotherapy, the disease was progressing, and the team decided to switch to radiation therapy. So after 12 sessions of radiation therapy, the right eye vision improved. The macular lesion was also healing, and the retinal opacity was also healing. But on OCT, we could see some hyperreflective foci, temporal retina was thinning, and some temporal outer retinal and RPE atrophy. So we saw the patient early last month, and he felt that the vision was improving. The view was hazy because of dense cataract, but on autofluorescence, we saw that what was the previously white patch now looked like a hypoautofluorescent patch, but the borders were hyperautofluorescent. We thought that the disease was still active, and the OCT showed some intraretinal deposits. We decided to give a trial of intravitreal methotrexate. Systemically, the patient was complaining of cough and recent onset post-nasal drip. So we got the PET-CT done was repeated, and there was an FDGA with nasal lesion. So we saw him last week where vision had improved, and he was now status post intravitreal methotrexate 1 dose. Right now we're holding on to the methotrexate just to get everything sorted out with the nasal lesion and to see how that goes. Now coming to the basics of what is mycosis. So cutaneous T-cell lymphoma has 2 major types, that's mycosis and Sézary syndrome. Mycosis is more common of the two, and intraocular findings with mycosis is rare, only seen in advanced cases. I found this case series of 30 patients with mycosis, wherein most of the ocular findings were lid tumors and ectropion, and 1 patient presented with uveitis. We looked into literature, found a few cases similar to ours, which were intraocular T-cell lymphomas. What was common in all the cases was that the patients presented with granulomatous uveitis and vitritis, and treatment revolved around methotrexate and radiation. Systemic prognosis was poor because of CNS involvement. So what helped us clinch the diagnosis in our case was that we sent it for the STAMP panel, and Dr. Rajesh Rao from Michigan and Dr. Vineet Mahajan from Stanford reported the first ever molecular diagnosis for an intraocular T-cell lymphoma. They reported a case of a 63-year-old male who complained of floaters, vitritis, and the vitreous sample was sent out for the TCR or PCR rearrangement test, and both eyes expressed the TCRG, and also for the next generation sequencing on the oncomine cancer panel, which is a 126 gene panel. So the results in this case was it expressed copy number alterations and the gain of the BRAF, that's an actionable mutation, and the loss of the DNA methyltransferase. So this highlights the importance of vitreous liquid biopsy in genetic analysis and precision in oncology. Just to summarize that intraocular T-cell lymphomas are rare. There are less than 40 cases reported, and vitreous liquid biopsy helps in the diagnosis and genomic analysis. These patients need a multidisciplinary input and a close follow-up because of the presentation of new lesions, and the treatment options have to be tailored. Thank you.
I always call Brian when I don't know what I'm doing, which is a lot. Brian, thoughts?
Well, I haven't seen a T-cell lymphoma since I was at Wills intraocularly, and it's very rare. It's a great case presentation, and it was handled nicely. I think in all intraocular lymphoma, you really want to try to maximize the visual acuity. So getting the cataract, getting the vitritis out, and then treating accordingly like you did is appropriate, as well as continue to follow the systemic.
I think we lost a bit on this one because I think that there was vascular occlusion, or probably the lymphoma cells occluded the vessels in that way. So I think the visual prognosis may be poor. Any thoughts?
I have a question about the kind of intervention and final outcomes. So sometimes you get these atypical lymphocytes, and that's the only thing you get clinically towards a lymphoma. And I've been leaning towards just sending for radiation treatment and telling them that this is keeping with lymphoma. Are people's thresholds been lowering over time because sometimes we just don't have a definitive answer?
I think it's a challenge, and it depends on your radiation oncologist and if they're willing to, if they trust you. Like you're a trustworthy looking guy, and I think that it does depend. Sometimes you do need to, watch the disease if you don't have anything definitive. Full workup, see if the other eye expresses. I think Hakan's work with aqueous MYD88 is also another alternative to see if things, materialize that way. It could be another line of evidence. I think it depends on your radiation oncologist if they're willing to treat. Very good. Next case, Kapila Mishra. He's we lost him here from Stanford, and he's at UC Irvine, where he practices vitreoretinal surgery and ocular oncology. Kapil.
Awesome, Prithvi. Thank you for the opportunity to talk about this case. This case actually came in like 2 weeks ago, so it's still evolving, and we'd love to hear your thoughts. I can add you to the chart that I discussed with you. So no financial disclosures. So this was a 65-year-old female. She presented to the ED at UC Irvine with 1 year of right eye vision loss. And really what prompted her to come in was her left eye. She started having peripheral vision loss. She was seen by an ophthalmologist previously who told her she had a retinal detachment and nothing could be done. And so she went home and then eventually saw a retina specialist who noted a choroidal mass and referred her to us, but at the same time was started on IOP drops, Predforte, and atropine. And then it was really when she presented with or left eye vision loss that she came straight to the ED. So nothing remarkable in terms of past medical history or past ocular history. So on her exam, this was all in the right eye. She was no light perception. She had an RAPD by reverse, motility issues, obviously complete field loss, intraocular pressure was elevated, left eye was normal, except for a temporal hemifield loss, which I'll show you in a second. You can see the photo here. There's a pretty impressive engorged neovascularization of the iris. There's some conjunctival injection as well, and there's a cataract with no view to the back. So this is a B scan of the right eye. It showed a lot of intraocular homogeneous contents, multifocal with a medium to high reflectivity. Really hard to kind of understand the morphology of it. And on every slice, there was it seemed to be a pretty impressive choroidal component. I just want to quickly show you the left eye. She has a pretty dense hemianopsia that was what prompted her to come in. So with the orbital signs, we were pretty worried about something happening behind the eye, and so we have an MRI here, a T1 fat suppression post-contrast, and radiology read this as an enhancing mass in the right intraconal space, extending posteriorly into the orbital apex.
Did they say possible tumor? Possible ocular lesion?
Clinical correlation advised.
Yes, right.
And so it went through to the optic chiasm and into the suprasellar region as well. This is not progressing. And so this is showing the suprasellar mass a little bit better. And then interestingly, up at the top, there was a dural-based mass of the superior sagittal sinus that radiology said that seemed pretty similar to the orbital mass, and maybe it could be similar pathology. So this patient presents to the ED, and we're left with all this information. So I'd like to query the experts in this room what you would do.
There's something wrong with the optic nerve. And it seems to be tracking back into the brain. So you gonna get a piece of it?
Yeah, we did. So we took an orbital biopsy. One of my oculoplastic colleagues said that intraoperatively there didn't really seem to be much tumor. It just seemed to be kind of inflammatory changes and thickening. And so their biopsy turned out to be just fragments of fibroadipose tissue, some fat necrosis, dilated hemorrhagic blood vessels, so really not too much. A few days later, neurosurgery went in and took a biopsy and a resection, actually, of that suprasellar mass, and it came back as a melanoma. So all the melanocytic markers came back positive, and they're doing next-generation sequencing to see if it's possibly cutaneous, but my impression is that this is a uveal melanoma that tracked posteriorly. Dr. Singh, what do you think?
The patient has nevus of aorta.
No. But a good segue to another case coming up.
Well, I think choroidal melanoma with the extraocular extension and going is rare, but they can track from the optic nerve. There are cases like that.
And I'm presenting a couple of these cases, but never seen one that went and caused a suprasellar mass. I was curious if anyone has seen it to this extent.
We published a case of a primary optic nerve melanoma that extended both ways. And also, I did an exoneration on an older lady exactly like this, but it was just neglected.
So that leads me to my next question is, how do you treat this? What would you do? Would you do exoneration, EBRT, immunotherapy, a combination of that? How would you manage all this?
She's 41.
No, this is a case report. She's in her 60s.
And mental status and everything's
She's
totally normal.
Totally normal, healthy otherwise.
Did you get a next generation sequencing? Do we know if this is?
That's in progress. So that.
That's going to decide what we make.
Yeah.
It's not surgically resected.
No.
So you have to go through immunotherapy or some kind of target therapy based on this. It's not surgically resected.
Would you even try to do anything surgically or no?
Is she
No need.
comfortable? If she's comfortable,
High pressure.
that's a glaucoma problem.
Yeah. So if it comes back as uveal, don't touch the eye at all. Just manage systemically.
Yeah, I would try systemics and adjuvant radiation if you could. You could do a proton or.
I think your hope is that the systemic therapy also gets what's the suprasellar mass, so that for visual change in other visual issues that they're good at.
Yeah.
And then the prognosis may be affected if that other mass in the brain is related to the primary.
Are they going to take a piece of that?
Yeah, so I mean, to talk about that, we were able to hunt down an MRI and it showed it was there from 2018, so it's just a meningioma.
Gotcha.
Yeah.
So that's important.
And you said you had a case that was in the, how did you know it started in the optic nerve, your case?
Because it wasn't in the eye.
But it went to the eye?
It caused proptosis, and we enucleated it, and then there's this giant nerve, and we opened it up, it was full of black stuff.
So it was like a meningeal carcinomatosis.
It was horrible.
All right.
Awesome.
Let us know how this works out.
Yeah, sounds good. Thank you.
It was a good case.
Going even further south in California, the champion of Bascom Palmer, where he was a retina fellow, chief resident, Anything else you did over there?
Longfellow.
Longfellow, right. Nathan Scott is a vitreoretinal surgeon, clinician scientist, and on faculty at UC San Diego. And he's going to talk to us about something in the eye.
Thanks so much for having me. Thank you for the invitation. So yeah, I'm going to be presenting a case that's also still in a little bit of progress that I saw very recently and kind of have an interesting story as well. So no disclosures. Well, she's going to start with a 31-year-old female. She has bilateral oculodermal melanocytosis who presented with a visual field defect and ultimately a choroidal mass in the right eye about 10 years ago. So a little over 10 years ago. This is what her slit lamp photo looked like in her right eye. The left eye looked pretty much exactly like this. You can see all of the extensive melanosis of the sclera. Here's the posterior segment. We were able to track down the photos from this. You see a large choroidal mass abutting the optic nerve here in the right eye. The ultrasound is also consistent with the diagnosis of uveal melanoma. The patient also underwent FA-ICG. On the top, you can see an early and a late phase of the FA, and then the ICGs are on the bottom, and we can see an altitudinal defect on the Humphrey visual field that's consistent with the location of her mass. So she underwent iodine 125 brachytherapy. I was able to track down the op note, and it looks like she had an 18 millimeter notched plaque. The biopsy was done with a 25 gauge vitrectomy setup. They used an angled or a bent 25 gauge needle. They did note that there was some subretinal hemorrhage. They endolasered over the site of the biopsy. I did confirm that they used a B-scan to localize the plaque, and they had pre-planned transpupillary thermotherapy after the plaque placement. So in follow-up, we were only really able to find images from their facility starting in 2016. So this is what it looked like in February of 2016. I'll point your attention to the small area of brown pigmentation right at the inferior aspect of the optic nerve. Looked pretty much the same in June of 2016. Then in September of 2016, there's maybe a question of some growth. The next image available was a TopCon image, so kind of hard to compare, but fast forward to January of 2017 and we see recurrence without a doubt. Maybe at this point I might ask what people would do here, because it's kind of interesting, at least to me, what happened next.
Ivana, are you...
Yes, I would say.
Yeah, I was going to say, I would call him...
Ivana, can you zap that?
I don't, so that was not in the records. Unfortunately, there were no real clinical records that I could get, just the imaging and the op reports.
That's
But
usually, it's
my
usually the
suspicion,
opposite. Like, you don't have the pictures.
Yeah.
Yeah, that's what you're asking.
Yeah,
We're going to guess 2,400
Yeah,
or worse.
no documented vision.
Yeah, that's what I would have thought. This person did very much want to salvage the eye, it seems, because they underwent a vitrectomy with endoresection, and the op note does report that there was concern for invasion of the optic nerve sheath, so they stopped, they cryoed their wounds, they washed with sterile water to prevent extraocular spread. The pathology was consistent with viable malignant melanoma cells, and the GEP was a class 1B with PRAME positivity.
Was this nerve excision? Like, because it's right on the nerve, right?
That would have been
Like,
very nice. Yeah, it was an odd.
It's a neurosurgical
thing to go after. And
They're being
neurosurgery,
built for that.
exactly. So based on those intra-op findings, they did recommend enucleation. She underwent an enucleation the next month. There was no monosomy 3 on the pathology. Sequencing showed a GNAQ and an SF3B1 mutation. An MRI orbits was done, and it didn't appear to be any orbital disease. And she was advised to basically undergo Q6-month MRI orbits. And I'll just point to the pathology report. Shows no scleral invasion, optic nerve invasion, extraocular extension, lymphovascular invasion, or perineural invasion. Fast forward to January of 2024. This is when I met this young lady, and unfortunately she was sent to me because the MRI showed a large new orbital mass. So now I'm sitting in here in clinic with a lady who has a new orbital mass 10 years after a diagnosis of In treatment of uveal melanoma, pathology reported no extraocular extension, all margins were clear. There was no systemic disease on a PET CT that was performed at an outside hospital. So I'm kind of asking myself, where did this come from? Is this even melanoma? And if it is it even uveal? She has extensive oculodermal melanocytosis. Could this be conjunctival or cutaneous? How did it even get there? Is it related to the surgeries? Maybe the extraocular extension was missed on the pathology. And probably most importantly, what's the most appropriate treatment for this lady? So oculodermal melanocytosis, nevus of Oda, I'm not going to go through all our fun facts here. I think most people in this room probably are aware.
You gave many options. What do you think happened?
Well, it's kind of part of the presentation.
Vitrectomy.
I think the answer is we don't know. I think, yeah, my final answer would be I don't know. It's really hard to say. But I did find this paper about nevus of Oda and the likelihood of increased cutaneous melanoma in these patients. And there's a possible increase according to the dermatology literature. Interestingly, they do not display classic ABCD alterations, and most of the studies show that you can actually just have a very benign oculodermal melanocytosis that actually is melanoma. And there are a few case reports where when they biopsied those, they actually had uveal genetic variation and did have a predilection for metastasis to the liver and lungs, which I thought was pretty interesting.
Meningeal.
Absolutely, yeah. So, yeah, they can have CNS involvement, leptomeningeal, dura as well, and there are case reports of parenchyma as well.
And primary orbital.
Yeah, that's coming up. So I sent this patient to oculoplastics. They tried to do an excision, but they noted that there was diffuse spread all over the orbit. They did not feel comfortable that they could get a complete resection. They removed her prosthesis, and then we started talking about what we were going to do next, which would be a full exenteration versus a large debulking excision, radiotherapy, or systemic treatment if this did end up being a cutaneous or a conjunctival etiology. I did get a Castle test on the orbital component, and it had the exact same mutations and GEP as the intraocular portion that was collected in 2017. So most undoubtedly, this was probably the same tumor that was on the inside of the eye, had spread to the orbit. And that kind of took out our sort of idea of maybe this could be treated with systemic treatment. So where did this come from? To your question, I don't think we'll ever know. I think we can postulate in areas, but in my sort of search for sort of looking for that, basically what I found, I won't go through all of this, was one, there were 3 cases that have been published where there's no histologic evidence of extension, and they did develop orbital tumors after enucleation. We know that microscopic extension is fairly common. 10 to 40% of enuc specimens have microscopic extension. Orbital recurrence following enucleation is super, super rare, about 1% of cases in these 2 studies, and then it does show increased risk for metastasis and mortality. The range of time in the literature is anywhere from as early as 3.5 months to as late as 40 years after enucleation. You can get orbital tumors.
I'm not sure if it was mentioned, but there is an increased risk of primary orbital melanoma in oculodermal melanocytosis.
Yeah, and here's a good review of the literature on exactly that. Because there's no real published data on treatment, we're kind of shooting in the wind here. This lady does not want an exenteration. She's 40 years old. She's a school teacher. She has 2 young kids at home. She wants nothing to do with even a large debulking surgery. Here is a paper looking at primary orbital melanoma, and about 24% of those patients did have nevus of Oda. Exenteration versus debulking excision didn't really seem to impact outcomes at all for these patients. The addition of adjuvant radiotherapy may reduce risk of death, but not metastasis, which I found interesting. And then there's no real data on this. It's a super rare occurrence, orbital disease after enucleation. Here's a couple of studies that aren't really looking at exactly what our patient has, but suffice it to say, adjuvant radiotherapy remains pretty controversial. There's a lack of any information on exactly what this does for outcomes, but it probably doesn't improve much, at least on the overall survival side of things. Some other treatment options is a pretty interesting case report from Jasmine Francis's group where they did monthly melphalan IAC for an orbital recurrence, and they showed that there was a 66 reduction in size, and then unfortunately it did recur at 9 months, but I thought it was pretty interesting. And then searching in the literature to find anything on systemic therapy, wondering if this is something where we might consider tebentafusp, given that we know that these patients do so poorly. We know that they're going to metastasize. We know they're going to die earlier than other types of disease. So is there a role for systemic therapy for these patients? And we just don't know. So back to our patient, she is still trying to figure out what she wants to do. So I saw her in January. She underwent that debulking surgery just a few months later, and she's been sort of wavering in terms of how she wants to manage this. There's my summary, and thank you.
So what would you do, Prithik? I have a couple ideas.
Yeah, I mean, I think the patient has to wrap their head around this, and if there's no surgery that she wants to do, I mean, this disease isn't going to go away. I think I would aim for systemic therapy, and see where we go from there.
So yeah, treat her as this is a metastatic lesion, and treat her that way. I would put in an implant, make her beautiful.
Yeah, there you go.
I think I would also order a skin panel for genetic operations. This might be responsive to anti-PD-1, even though it came back with those mutations. It's a very unique case.
Yeah. I think that the original lesion itself was already in the orbit. Like, I think it was already past the optic nerve. It was the way that it like lifted up the nerve, and there's a subset of these that just, will be peripapillary and find their way back. And I think it was probably, and if we're doing the case today, we probably would have gotten an MRI to plan it with the, the eye physics plaque or whatnot. And we may have seen it at that point, but I think it was already there.
What's your thought of it being seated during the vitrectomy in the end of the resection?
I'm sure something like that happened.
Yeah.
I think it was probably back there. You just couldn't reach it, and it was probably not fully treated to begin with. Yeah, and it's bad disease. Great case.
Yeah, thank you.
Thanks very much for the meeting organization and for asking me relatively recently to present a case. So I'm bringing something to you that we may have already heard the answer for this afternoon. This is not MS separated in time and space. I have no conflicts. This gentleman was sent to me in February 2023. He's 35, out with his dog. You can see that he's got heterochromia. He's had heterochromia, according to him, since childhood. It changed a little bit in high school, but it was always there. He'd had a squash ball injury. Nobody had ever seen anything else, and he had noted an infranasal scotoma and been put on glaucoma drops for elevated pressures and was developing a cataract. I turned out to be his worst nightmare. This was the lesion with the pupil dilated, and you can see that he ended up enucleated. He had an AJCC, probably T4B, clinical staging of this large uveal melanoma that was sort of cilio uveal in origin. But actually there was more to it than that. So you can see this is where the root is. There are melanoma cells in all of this. There are melanoma cells in the trabecular meshwork. And all that stuff on the iris was melanoma cells. He also had posterior metastatic lesions all the way through the retina. So what was behind it? That was the iris itself. And I don't know if any of that was ever heterochromia. I think it was all abnormal cells. It went through the angle. It was packed in there, but all that brown stuff in the back was also melanoma cells. I don't know how it was that nobody'd seen it before and that he'd only recently had symptoms. But as part of the workup, we do an ultrasound of the liver because we can. He was young with a big tumor. It would be normal protocol for us to get an MRI with Primavist, which is your same as Eovist, and also a PET scan. And we found a thyroid nodule. We also found his renal cell carcinoma. And he had an FNAB of the thyroid so that they could try and stage what to do first. They thought it was papillary thyroid cancer. He underwent a partial thyroidectomy that was even a little bit more than that because it was all tangled up in his nerve system. He also had a scalp intradermal melanocytic nevus that was BAP1 retained. And my concern was, what was this 35-year-old guy with a family history, had a prostate cancer, a breast cancer, and lung cancer, and a smoker, but none of the other ones that you would think of as BAP1 tumor predisposition syndrome, but that was certainly my worry about it. And I'm an ophthalmologist, so I sent them to the hereditary cancer group at our center who do the testing. And they send that specimen to Ambry Genetics, which failed to identify any abnormality in BAP1. But my question was, is that enough of a test? Is the test the one that you need to do? What are the false positives and negatives, and what else do we do with them? And Colleen was on this paper about underreporting of BAP1 tumor predisposition. So I'd love to hear more what you think about this. The recommendation was lifetime surveillance, and actually they went back and looked at his renal cell carcinoma, and it was BAP1 preserved. And this is what goes from ocular melanocytosis to uveal melanoma. He didn't actually have oculodermal melanocytosis at all. So we know that there's a pathway, and then we know that there's an evolution, but how was he going from teenagehood to this stage? And then how do we as a clinical community actually keep guidance on these patients in a way that is practical? And again, I think we heard at least one answer. There are 3 sets of guidelines, but in the absence of a definitive test, can you make a play for actually having him on surveillance, and how often anyway? So the European guidelines are the most recent set, and I would love to hear around the audience what people are doing in other centers, whether you actually have it established, and how you make a play within your system for the resources to do that. So the pathology report provides certain information, and the good pathology test is meaningful, consistent, independent, and practical. But in fact, I think that goes for all the genetic tests and everything else we've been doing. So the personalized oncogenomics world is supposed to help these patients and their extended family. At this point, there isn't somebody else in his family to advise about this.
I follow the Colleen guidelines, whatever she says. Any thoughts, Colleen, on?
Case, I think it's always surprising. You would think for sure this guy has BAP1, but when it's negative, I think there are other genes, and BAP1 is only a small percentage of all the genes that are responsible for uveal melanoma that is like a hereditary predisposition. So like one important gene appears to be POT1. There are actually many that we have identified that I think the main thing is that we have to publish our cases. For our patients that we've looked at, we usually get like a 77 gene panel from one of these companies when they see the genetic counselor. So I think we've identified like quite a variety of genes that are important in causing these predisposition syndromes.
And syndromic with another grouping, like a specific one. So there's similar.
And some genes you would be surprised, like, oh, I've never heard of that one, So there are really quite a few. So I would recommend a broad panel testing for your patient. Would be a really good idea.
But how do you decide which panel and which technology?
Mm-hmm.
Melanoma registry at the Cleveland Clinic that included uveal melanomas, and when we took out our uveal melanomas, I think it was about in the mid-20s, about 25 or so, we found about a 20% hit rate. There were some BAP1, but there were all sorts of other things that you wouldn't expect. And that is actually, we published that in JAD earlier in the fall, and we hear that guidelines might be changing in terms of testing for any melanoma because we included mucosal and uveal. And I would do as broad of a panel as you can. So we ended up using the most broad panel that we had access to from a research perspective. That was Invitae's. 84 gene panel, but typically you get about 70 genes. But if you send to genetic counselors now and point them out to our JAD paper, they will be well informed as to what to test.
Colleen, is there such thing as mosaicism for BAP1?
One just based on the expression, right? Because you should lose BAP1.
I mean, I think there could be some weird circumstances, and I know, Muhammad would tell you this better because he's really the geneticist, and I'm not. But I know we had a patient, and they actually lost their mutated BAP1 copy. Like it was such a weird situation, like in their tumor tissues. So that's a great question. Whether there's mosaicism, I don't know the answer honestly. But again, back to the large panel, you need to work with a genetic counselor. That's
we have,
so helpful.
my worry is, are we missing something? Because
you need
I
a
think
large
there's an
panel.
interplay.
We use typically, our counselor uses usually a 77 gene panel, kind of like similar to Pauline.
Yeah, and this was
use
like
a large panel.
41 panel, so, okay.
76.
Excellent. Thank you very much.
Thank you.
Last but greatest, that's what he told me to say. Dr. Maturin from Duke University.
Well, this was an add-on when I told Priti about this patient yesterday night. And he said, why don't you present 3 slides? So there are 3 slides.
I'm counting.
Not counting this.
No.
4. Okay, so now that we start with the 3 slides. So this picture is from, it's a 60-year-old lady with a history of metastatic cutaneous melanoma. She was treated originally with immunotherapy, and she didn't tolerate that. So for a few months, she was treated with immunotherapy. She didn't tolerate, so she was referred to us just to check on her eyes. And so we saw her first in May of 2023. A few months later, she came with complaining of floaters. And those are the floaters.
Ooh.
Vitreous metastasis from cutaneous.
Vitreous opacities, that's absolutely right. So we did a vitrectomy, diagnostic vitrectomy, and it showed and it proved that there were melanoma cells.
This is post-vitrectomy?
This was...
Good job, Miguel.
Well, yes, it was. Yes, it was. And I didn't do the vitrectomy.
Did you do intravitreal malformation?
It's one of your trainees
who
did the vitrectomy.
I take no responsibility.
Okay.
But you can sometimes give intravitreal melphalan at 25 milligrams for these, and there's some response.
At the, after the vitrectomy.
You're starting, was that a question or a comment?
It was both.
A comment, okay.
Did you do it? And you could if you wanted to.
So
why didn't you, is what he's saying.
She was treated with BRAF inhibitors, not by me. And we saw her last month, and she's with good vision, everything, and her disease is under control. And I don't know if you have any experience with some of these medicines going into the eye.
Pauline, any thoughts?
My 3 slides are done.
Wow. Are you sure this wasn't the vitrectomy? It must be the great retinal surgeon.
Did you mix up the slides?
I did train him apparently.
She overcame the vitrectomy. It was clear.
That's a good point.
Why we did it? Why? To make a diagnosis, we were not sure that was
cells
melanoma.
Why
how common is cutaneous melanoma giving metastasis to the vitreous? We don't see that.
No.
You see it all the time.
All the time. Okay.
Patient has established diagnosis cutaneous melanoma. Patient has established diagnosis of metastasis. Now she has metastasis in the vitreous, so why do you have to do vitrectomy?
I'm sorry, are you challenging me the vitrectomy, or I'm talking about the treatment that went into the eye with these results?
By now we have seen
that's we need to comment.
Many cases of vitreous or retinal metastasis from cutaneous melanoma, lung, even breast cancer. We have seen many nowadays because patients are living now with metastasis. And we are seeing more and more of this. We never saw them before.
Correct.
So I would say that a clinical diagnosis like any other metastasis is a reasonable one.
And what's your opinion on the treatment? What's your opinion on the treatment?
I have an idea.
Okay, good. What would be your choice? Seriously, I think that's a great case to share.
So in this setting, like, what would you choose to treat? Like, would there be a...
If you say eye and you extend that to brain, so BRAF mutant brain mets, the first line of treatment that was shown in a cooperative group trial that we participated in at the clinic, is that it should be ipi-nivo first. The double agent immunotherapy, BRAF mutant melanomas are a little bit more sensitive to, and then you get that long duration of response. This will work. So there are plenty of trials that look at, not at vitreous, but at brain, that show that BRAF MEK inhibitors are not perfectly penetrant, but they are definitely penetrant enough to cause tumor reduction. And then the question is, how long will this last? So typically speaking, when we look at BRAF MEK inhibition in stage 4 melanoma, the median duration of response is somewhere between a year and a year and a half. And then at some point it loses its steam, and then you're going to have to do something else. And then again, this is that tumor burden thing, right? Is if you have a lot of tumor burden, then that duration of response is going to be like 3 to 4 months. If it's only in the eye, which is a small tumor burden, then it may be more like 2 years. But at some point there is resistance, and then you're going to have to do something else. There's about a 20% chance that all you need is that. You can induce just enough immune response or something, sort of immunotherapy light, something where you can actually get a prolonged response, but then you can't ever take them off drug.
So it's been a year. Should I think about referring the patient to Cleveland as an example?
The patient received the Nivo EP already, yeah? You said immunotherapy is already given for this patient?
Yes.
Then it's difficult. I think Pauline is right. It's going to recur sooner or later. But in the past, when you had the vemurafenib, BRAF inhibitor trial, phase 1 trials, trying to see if it goes to brain or not. Actually, in fact, the concentration is very low. So we thought that it's not going to go there, but then it works in the brain. So that means if the tumor goes, there's a breakage of any barriers can go. So I'm not surprised to see the vitreous involvement and improvement. But then it's my first case I've heard. But that's a very interesting case. But
yeah, so I'm impressed too, even though Arun isn't.
We're done. Thank you so much. It was a lovely meeting.
Great. Thanks, Miguel. Thank you. I think that's it. Thank you very much for all coming here, and to our generous sponsors who are so engaged in the field of ocular oncology today: Acure Insight, Aura Biosciences, Castle Biosciences, Immunocore, Immunogen, which is an AbbVie company, IDEA, Optos, Delcath, and then the Adler Fund for Ocular Innovation. I'd like to thank our awesome AV crew who did a good job keeping us together. Can't do anything without our wonderful faculty who have come from very far and very near to educate us and enlighten us. My team at Stanford, Rose Angel, Marissa, thank you, and to the team from iVista, who are awesome as always, Jeremy. I have to admit that for me, this is a personal awesomeness for me to be with you guys. I do this so I get to hang out with my really smart friends and who teach me a lot and work really hard taking care of patients, and I think we are all grateful for everything you do and helping to move the field forward. So thank you. We'll see you next year.
Thank you, British. Thank you.